It's a pleasure to welcome you back again for the third WFNS NextGen Forum webinar. And we have a distinguished faculty and very promising young neurosurgeons today who will be participating in this webinar today. We have first the master lecture by Professor Caldwell, who doesn't need any introduction to neurosurgeons in the world. But I have to introduce him, a very close friend, or my close friend, India's close friend, and a teacher par excellence. He's professor and chair, Department of Neurosurgery, University of Utah. He's the current president of World Academy of Neurological Surgery and has been the past president of WFNS. Very active, both clinically and as a teacher. And his talk would be first orbital surgery for neurosurgeons, something which is neglected in many departments. He will be followed by, as is routine in our this NextGen Forum webinars, by case presentation by young neurosurgeons who will be supported by the faculty. And the order would be first Dr. Al Hussein from Egypt, who will be followed by Dr. Yusuf Sheikh from Pakistan. And then he will be followed by Dr. Ruth Missel, a very eminent young neurosurgeon. She is actually a Nobel Peace Prize winner 2017 from Australia, from Melbourne. She will be followed by Dr. Hassel Sorai from US, and then finally by Dr. Jeppe Lofert Haslund. And I'm told he was down with COVID, but he's been kind enough to present do his presentation from Denmark. And these young neurosurgeons will be supported by Professor Ijad. Actually is unwell today, so he will not be joining us today. But the other faculty would be Professor Salman Sharif, Professor Isabel Germano, who is in actually a flight. I hope she can join us. And the flight allows her to communicate with us in Zoom. And then we have Professor Sarah Wolson from Brisbane, Australia, and then Professor Teet Mathisen from Denmark and Sweden. So without further delay, may I welcome and request Professor Caldwell. Bill, please go ahead, your presentation now. You're muted. Bill, you are muted.
So it's an honor to be here. Thank you so much. And I'd like to just share my screen with you. And I'd like to talk today about a topic that I think has been neglected, as Basant mentioned, and it's really our next frontier. Which is the orbit. And when I was a young neurosurgeon, we were still learning the paranasal sinuses and learning how to do transfacial surgery, transnasal, transmaxillary. But I think the orbit is an extension of the disease that we treat in the head, as well as we can use approaches down along the orbit and through the orbit to reach intracranial disease. And I'll move along here, and we've got 20 minutes. Basant, if you could just give me a heads up of maybe 5 minutes before, I'd appreciate it. So this is where I work. This is the University of Utah. It's in the foothills of the Rockies. It's a beautiful area. And some of southern Utah has the most dramatic parks in North America. And I encourage you to come and visit us and visit the parks. I show this case as an example of the problem that we have in skull-base surgery, in that there's very little evidence basis. We're dealing with often rare disease, and it's not uniform, and the operations are not uniform, and the treatment is very individualized. So we really have to share experience of our experienced neurosurgeons to help bring along and teach the best treatments forward. This was actually an adenoid cystic carcinoma. She lived in Montana, and she went blind several years before, but came in extremis, and I removed the facial part of the tumor and the transcranial part of the tumor to stop herniation. So where are we going? I think the skull-based surgeon must be familiar with the orbit. It's relatively simple anatomy and it's forgiving. And I think people don't appreciate this, but I think when the disease starts to go into the orbit, the neurosurgeons treat this as a no-fly zone. And I will tell you that our techniques and our surgical approaches are very, very good at chasing the disease in the orbit when we need to. And we're all familiar with the anatomy of the cavernous sinus, the third nerve, the optic nerve, the carotid artery and ophthalmic artery. 4 crosses 3 here at the superior orbital fissure, and V1. And I'll go through some of the anatomy of the orbit as we talk about these approaches. I think it's important to recognize that a lot of the nerves and the arteries and the veins start in the lateral compartment of the orbit and they go medially as they go distally in the orbit. So here you have 4 crossing 3, and you've got V1 and the upper division of the third nerve of the oculomotor nerve, the optic nerve, and you'll see the ophthalmic artery also comes in and crosses over the optic nerve. And this is important when you're operating in this area, and we'll talk a little bit more about that. The bony anatomy is very important. The superior orbital fissure, the annulus is in, and all the nerves that run through the annulus is in. So when I think about orbital surgery, I think about diseases that invade the orbit from the intracranial space, such as meningioma. And then I also think about approaches around the orbit to reach intracranial disease and cavernous sinus disease. We've written a review on this recently. And I think most of the transcranial approaches are very familiar to all the neurosurgeons. They're used as journeyman approaches on a daily basis. But if I'm looking at disease in the orbit, I think about a transcranial approach for disease that's involving the superior part of the orbit and the lateral part of the orbit. So in this region here. And if you're thinking about disease in the medial and the inferior part of the orbit, then transfacial approaches are ideal. And the endoscope allows us then to use these approaches to do a very, very minimal invasive approach to disease involving the medial and the inferior part of the orbit. So here's a hemangioma of the orbit. This man was losing vision. He also had some proptosis, you can see here. And what we'll do is we'll do a transnasal and transmaxillary approach to combine this approach to get exposure to the inferior and medial part of the orbit. So we'll remove the middle turbinate here and then expose the inferior part of the orbit by removing the medial maxillary wall. So now you can see the inferior and medial part of the orbit being exposed. And here we are now. Here's the periorbita inferiorly. And the disease removal is similar to what we would use transcranially. So we knew this was likely a hemangioma. There's the periorbital fat. And what we'll do then is we'll debulk the center of the tumor and then cauterize and reduce the tumor to its vascular pedicle and then remove this. So very, very similar to how we would remove a tumor using any other approach in the head. And this is why I said our facility with this type of surgery is very amenable to application in the orbit. So here we are removing the tumor. Here's the vascular pedicle right here. We can go ahead and cauterize that. And then in this particular case, there's no reconstruction. There wasn't enough violation of the orbital wall. We'll just obtain hemostasis. And then you can see postoperatively, the eye is reduced and the pressure is off the optic nerve. So what about the disease of the superior orbit? And I'll show you this case, which is a young man losing vision in his left eye with his schwannoma. So we'll use a transcranial approach in this case. Frontotemporal is simple. It gives you access to the lateral side of the orbit and the roof of the orbit. And we'll go ahead and then just drill the roof of the orbit. And you can see here is the levator muscle. And we'll come in beside the levator muscle and be careful of the first division of the trigeminal nerve. This is a tumor off of the trigeminal nerve in this area. We're opening up just medial to the levator here. And we'll dissect the levator over laterally, and then you see the tumor, okay? And so again, this is like removing an acoustic in the posterior fossa. You're going to dissect the tumor, you're going to debulk the tumor, and then come in a pericapsular fashion and remove the tumor. And so this was a cystic schwannoma. So we'll go ahead and debulk it and then continue with our dissection around it. And again, remember that the periorbital fat is very forgiving. And as long as you know where you are with respect to the optic nerve, you'll be able to preserve those important structures. You need to know your approach to the orbit. So we got into the frontal sinus here. We'll plug that off and oversew a pericranial flap on the way out. And that tumor has been removed. Now, these schwannomas of the first division can be very interesting. We've written a series of these, Sam Malmefti and I, just recently, that they can be sporadic and they can be skip lesions. So what you're looking at here is a young woman with proptosis. She's got these cystic schwannomas involving the cavernous sinus and extending all the way out on the roof of her orbit. And it's discontinuous in that there's areas of the nerve that are involved and there's areas that are normal. So we'll do an orbital frontal craniotomy in this case. We'll remove the orbital roof with the frontal bone flap and then go ahead and expose the region of the tumor in the roof of the orbit. So what we'll do is we'll remove the tumor all the way back from the anterior part of the orbit all the way back to the cavernous sinus. And so we'll peel up the lateral wall of the cavernous sinus here and remove the tumor along the entire course of V1 from the Gasserian ganglion right to the orbital roof. So here's cystic schwannoma within the cavernous sinus. We've opened up the cavernous sinus using a window that we're able to remove the tumor. Again, this is fairly straightforward. We'll dissect it by debulking and then coming around the perimeter. And then now what we're doing is we're chasing the tumor along V1, along the roof of the orbit. This is a superior orbital nerve that's involved. And you can see that there's areas where there's these normal areas of nerve and then these cystic and tumorous areas of nerve. So we don't know why this happens, but it's a unique variant of schwannomatosis. And we've had several cases like this over the years. And you can see here's a nugget of tumor that I'm removing along V1 in the roof of the orbit. And then we want to preserve the normal nerve. Remember, it's very important for corneal sensation that we preserve the function of V1. So we'll go ahead and close up the periorbita and then close the head. And what we'll see at the end here is you'll see absolute reduction in the amount of proptosis that she has now and reduced mass effect from the tumor. So this phenoorbital meningioma is a problem. It involves the bone. There's hyperostosis and mass effect from the hyperostotic bone. Here's a case in point. Here's a middle fossa tumor that was removed. And this woman kept going back to the neurosurgeon and he kept telling her that the tumor was gone, but you can see how much proptosis she has. This is as bad as it gets. This is a terrible one. It's involving the orbit. And look at the tumor growth. So it's growing in the orbit. It's growing outside the cranium in the temporal fossa, and it's growing in the middle fossa. And there's hyperostotic bone in between. So this is the problem with these cases, is that it heavily involves the bone, and the bone must be removed. So I've become very aggressive with these cases, and we do a very aggressive removal of the bone, removing the orbit of the orbital roof, the lateral orbital wall, and right up to the orbital rim. Now, the beauty of these cases is they often don't involve cosmetic deformity of the orbital rim. So you're able to remove the abnormal bone and leave the orbital rim intact for cosmesis. And what we do is remove all the bone, all the involved bone. And so here's an example. Here's a man that came to me from another state, and he's got tumor involving the bone. There's no soft tissue except in the temporal fossa, all the bones involved. And so we target the removal of the bone, looking at the abnormal bone on the CT scan. And so we'll remove all that bone and decompress the orbit. Now, I used to reconstruct the orbit, and I was very unhappy with the results. This is this woman. She's actually from Eastern Europe, and she's coming in herniating here. You can see the temporal lobe pushed over past into the notch. And so we operated on her urgently. And I'll show you the extent of the disease that you can find with this. So right frontotemporal approach, the bone is very thick. There's tumor in the temporal fossa involving the muscle. So we'll drill all that out. Now you need to see all the bony structures. So we're removing the clinoid process now, and you can see how thickened it is. This is like archaeology. You're removing bone, you're looking for normal anatomy, and you can see how thickened the clinoid is in this case. Decompress the optic nerve. Here's the lateral orbital wall, superior orbital fissure that we've decompressed. And then I'm going to show you how we remove the tumor in the orbit itself. Because if we don't remove the tumor in the orbit, it'll be a nidus for recurrence, and you're not going to help her with her proptosis. So you start out near the orbital rim, you find the interface between the tumor and the periorbital fat, and march backwards. Now, when you get back towards the annulus of Zinn, you'll have to decide how aggressive you want to be and whether you're going to sacrifice any of the orbital muscles involved. In this case, we didn't need to. The tumor was able to be peeled off fine. And you'll see the extent of orbital reduction in this case that she's achieved. So we removed so much bone. We did this in 2 stages, and we did a post-op cranioplasty. Look at the optic nerve now. You see how much her eye has been reduced. Now, when we took her back 2 weeks later, we put a cranioplasty in, and I'll show you what she looks like at the end of the case. You can see now, here's her eye completely reduced. Okay, so this is the kind of aggressive surgery that we must do to be able to reduce the eye in these terrible cases. So I looked at my results in 38 patients. We have many poor patients now. This is the results, but I will tell you that I thought that we would cause enophthalmos in these patients, and we don't. And the reason is, I think there's so much disease around the eye just does not reduce that amount. If you decompress a normal orbit, it will cause enophthalmos, but not in these particular cases. You can see we measured the amount of proptosis, and none of them became enophthalmic in this series. This is just to show you that occasionally it's more than just tumor that's causing proptosis. This is pneumosinus dilatans. This is something that Ann Osborne taught me about, that you can get blistering of the sinus that can cause proptosis as well. And it can be blistering of the paranasal sinuses and cause proptosis. In this case, we'll use a combined approach, transcranial approach, remove the tumor, and then we'll come in supraorbitally as well. And our ophthalmologist colleague, Bhupi Patel, will remove the tumor in the anterior part of the orbit that is hard for us to reach underneath the orbital rim. So we're working above the eye here. And in this particular case, he was such a young man, he was in his 20s. We'll take a piece of the muscle here to try and achieve complete removal to avoid recurrence. So we use aggressive surgical resection. I have not now formally reconstructed the orbit with these cases. I know this is controversial, but I've been happy with my results. So I will tell you another opportunity. I think if you understand the orbit and you understand the anatomy and you use the approach to its advantage, is one that we've done is if you look at the evolution of the frontotemporal approach over 50 years, it's been more and more minimally invasive. So it was really originally popularized by Yasser Gil in 1969. But we realized that when we did these large cancer operations, here's a woman who's going to have an orbital exoneration, you can actually come a little bit more from the front through the orbital area, and you get a very good look at the cavernous sinus. Here's the anterior loop of the carotid. And these are operations that are very well tolerated because you're barely touching the brain. You're coming right directly anterior. And so we thought that we could use that to our advantage in getting to the region of the cavernous sinus. And this is an ophthalmic surgeon's approach that we've extended back to the region of the cavernous sinus. It's about 4 centimeters along the lateral orbital wall. And you can use this to your advantage to remove lesions of the cavernous sinus, and you avoid brain retraction. So you come extradural, you come extratemporal, and you peel up the lateral wall of the cavernous sinus. And the advantages is that it's you don't interrupt the temporalis muscle. There's no brain retraction, and it's entirely extradural. So here's a woman with a cavernous sinus lesion. She had had a bone marrow transplant 2 years previously, and they didn't know what this was. So what we'll do is we'll set her up and do just a lateral orbitotomy, fork the incision over the lateral canthus, and then remove 15 millimeters of the orbital rim. I use a C1 bit for this, just so we don't remove too much bone. And then put your plates in here so you get perfect apposition on the way out. And then after we remove that, we can come directly back through the pterion, through this sphenoid ridge, and find the temporal tip, and then come extradurally and lift up the lateral wall of the cavernous sinus. And what you see here is you see a very firm lesion in the cavernous sinus. We did an excisional biopsy, and this turned out to be a unusual tumor related to her previous bone marrow transplant. It was a smooth muscle tumor. So it takes about half an hour to do this operation. It's very simple, and there's no formal closure because you're entirely extradural. You just close by replacing that little bone flap with the lateral orbital rim, and I use a subcuticular stitch, and then remove the eye protector. So here's an example of a cavernous sinus meningioma in a 70-year-old man. He's losing vision. And what we can do is we can do exactly the same operation that we would do with a frontotemporal approach. Here, I've removing the clinoid through this approach and decompressing the optic nerve. And we're here in the lateral wall of the cavernous sinus. Okay.
Lateral aspect of the trigeminal nerve with all of its branches.
And again, no formal closure.
We replace the lateral orbital rim with mini plate.
And this is what he looks like post-op. You can see we've decompressed the region of the orbital apex. We've removed the anterior clinoid process, decompressed the optic nerve, and this is his cosmetic result. So there's no wasting of the temporalis muscle with this approach. So we use this for small targeted lesions in the cavernous sinus, and we only remove the lateral orbital rim, and we keep the wall now intact. And finally, I just want to talk about this disease, which is a rare disease, but neurosurgeons get involved with optic nerve gliomas. And I'm going to show you a case where we developed a one-step approach. This is usually done by a transcranial approach by the neurosurgeon and a transorbital approach by the ophthalmic surgeon. And they usually come supraorbital and over the globe, and then remove the tumor from the anterior aspect. We're going to do it in a one stage through a transcranial approach. And so it saves the incision in the face, and we also get one step removal of the pathology.
This case demonstrates a one-stage cranioorbital approach.
I'm going to let the video play.
Remove the involved optic nerve from just anterior to the chiasm to the globe. This is a 28-year-old woman with progressive visual loss. She had an enhancing lesion in her right optic nerve that was progressing. She had 2 biopsies by the ophthalmology group that had demonstrated a low-grade glioma.
You can see the enhancement in the nerve. She's blind in this eye.
Loss and the progression of her tumor, we offered her resection of her right optic nerve. She's positioned here for a right frontotemporal approach, for a frontal orbitocranial approach to the optic glioma. The incision is outlined here. and we'll perform a myocutaneous opening and a frontotemporal flap. After elevation of the flap, the roof of the orbit is drilled, and we perform an extradural dissection and identify the meningo-orbital band, which is cut and dissected down to expose the clinoid. We then drill the lateral and the superior orbit. The periorbit is identified and is left intact at this point. We then unroof the optic canal and identify the optic nerve. After exposure of the superior orbit, we continue our removal of the roof to the level of the globe and then remove the anterior clinoid process. After drilling the optic strut, we loosen the clinoid, which is removed. The carotid is identified. We then open the dura in a T-shaped fashion, following the Sylvian fissure, then teeing it at the frontal base and the anterior temporal dura. We identify the intradural optic nerve and carotid artery. The chiasm is identified. We'll then plan to divide the optic nerve approximately 2 millimeters anterior to the chiasm to respect von Willebrand's knee. After the optic nerve is transected, we then open up the falciform ligament and follow the nerve within the canal. The annulus of Zinn is identified. We will then open up medial to the levator palpebrae, taking care not to injure the frontal branch of V1. We then identify the proximal optic nerve in the orbit. Cranial nerve 4 is identified exiting the annulus of Zinn, and we'll dissect immediately on the optic nerve, which is thickened in this case. The nasociliary nerve is identified crossing the optic nerve. We then continue our dissection on the optic nerve using self-retaining retractors to hold back the periorbital fat. We then identify the region of the optic nerve that was biopsied previously, which is very scarred. And we approach the globe. The nerve is then transected just as it exits the globe. We then elevate the nerve and free it of its investments and dissect it back towards the annulus of Zinn. Now, the key step in this procedure is to gently dissect the nerve from its investments within the annulus of Zinn without interrupting the nasociliary nerve or the fourth nerve. We're able to remove this as one specimen from the chiasm to the globe. We then close by reapproximating the annulus of Zinn and reapproximating the periorbita. We then perform a reconstruction of the orbit using a MedPore preformed plate. It is titanium and MedPore. In this case, we enter the frontal sinus with the frontotemporal flap, and this is isolated by sewing a vascularized pericranial flap over the defect. The bone flap is replaced, and a cranioplasty of MedPore is fashioned. The muscle is closed in separate layers, as is the scalp. Her postoperative imaging demonstrates complete resection of the optic nerve on this side. And she was stable from a neurological standpoint postoperatively with a mild ptosis that improved over the next 6 weeks.
So finally, in the last 30 seconds, I'd just like to talk about this problem that we see. This is very common in America, where we have sphenoorbital meningioma, resected 2004. You can see it's subtotally resected. And I call this failure of insufficient surgery, and I think it's happening more and more. So the patient undergoes, again, partial resection a couple of times, orbital surgery ×3. Patient has radiation more than once, gamma knife, and now she's got a real problem where she's got cavernous sinus invasion, the carotid's encased, and the orbital prosthesis here is just floating, and it's now threatening the contralateral cavernous sinus. So in this case, we'll do a radical exoneration. And I think it's important to remember that once the vision is impaired on the ipsilateral side, then we consider that as an indication for doing a more radical resection. So we're not interested in preserving function at this point. And what we'll do is we'll do an en-bloc resection of the entire area. And these cases require tissue replacement because they've undergone radiation, and you need vascularized tissues. So we'll use a thigh free flap in this case, but come around the case and everything needs to be dissected. And the middle cerebral artery here is involved. Here's the right optic nerve, carotid artery. We'll ligate that. If we need to bypass, we have to do that. We'll do a balloon occlusion test beforehand. In this case, we were able to not do a bypass because she passed the balloon occlusion test. Here I'm ligating the carotid, the supraclinoid carotid, and isolating the tumor from the middle cerebral artery. And so these are arduous cases, but I do think, you know, if this woman had had more aggressive surgery at the beginning, we might have saved her this terrible procedure. And so this is sewing in the free flap. So ultimately, we're left with this kind of picture. These patients are sick, and they often spend a long time in the hospital, and you're fighting CSF leaks. So in conclusion, orbital surgery should be familiar to skull base surgeons. It's the new frontier. It's important to know the anatomy. It's forgiving. We can use our techniques. And I think this is for the next generation to really refine and perfect. Thank you very much.
Thank you, Bill. That's an extraordinary presentation, and you have given a very nice overview of what all things the neurosurgeon should be doing, actually, which we don't do. As you rightly said, many departments, that's a problem because this is thought to be no entry zone. But as you rightly said, this is a forgiving area, and obviously once the vision is affected, like in a meningioma, one has to be very aggressive. And I just for interest, I'll tell you about maybe in the last couple of months, we have done one patient of similar thing, which you showed optic nerve glioma, which was imaging wise was diagnosed optic nerve glioma. She was being followed up because she had some vision. And finally, when she was blind, we did exactly the same procedure which you showed. But the biopsy report, the final histopathology came as a solitary fibrous tumor of the optic nerve, hemangiopericytoma type of tumor. And that was a surprise because that was going on for, and that's supposed to be an aggressive tumor, you know, hemangiopericytoma, a little bit aggressive tumor, grade 3. But this thing was going on for the last 5 years. She was being followed up because she had, and that the diagnosis was optic nerve glioma imaging wise. So we do less frequently than what you showed, but we sometimes do that. My one question before I take questions from the faculty and the audience is, how often do you see this sphenoorbital meningioma involving the muscle and the skin?
Yeah, so it's unusual. That was a very dramatic case that I showed you the surgery of, but you've got to watch it. It can invade the muscles, and it's often in recurrent cases where they've had previous surgery, and you have to decide a priori and discuss with the patient whether they're willing to have some muscle removed. We try to preserve the muscles, obviously, for functional outcome. But if the patient's already got impaired muscle function, then it's reasonable, I think, to take the muscle with the tumor and leave them with a non-functional muscle. Now, the ophthalmologist can always straighten the eye. That's not a problem. And these people often have diplopia already because they're...
Sorry, Bill, I'm asking a temporalis muscle. I'm asking the involvement
temporalis muscle okay.
And the skin. I'm sorry. I'm sorry.
Yeah, I'm sorry. Yeah, I was talking about the ocular muscles. But yeah, I've seen it a few times. It's only in these very aggressive ones like that.
Yeah, I have a few cases where these, especially the elderly 70s who have this tumor, and they've been quite indolent. You know, I have left the muscle there. The temporalis muscle is all involved. And the patient has no symptoms except the imaging shows that the tumor is there involving the muscle. We have taken off the bone, we have taken off the dura, there is nothing intracranial, but the muscle that is tumor is there, which we are following it up. I haven't done anything to that, no radiation, nothing, just following it up. And that seems to remain like that for quite some time. I mean, we have years of follow-up now. So I'm just wondering, you showed one case where the muscle was involved. So I'm just wondering, how often do you see that and what do you do about it?
If they come to me and they've already had several procedures, then I remove everything. I try to remove everything because they're in trouble, like that last case. But I think that's very reasonable at the very beginning to leave some tumor, to leave a functional temporalis muscle. I agree with you.
Yeah, Bill, I think we see very different kinds of patients with different circumstances where we practice. I agree with Basant that I view the meningioma as a mesenchymal tissue that homes pretty well in muscle and doesn't necessarily behave very aggressively, although it will have a very high risk of invading both the temporal muscles and ocular muscles. And I think the cases you show, Bill, don't you have the impression that maybe these patients would have done better if they haven't been inappropriately radiated?
Oh yeah, I think that's a big part of it, Pete. As you know, we've published in some of these cases where Sam El-Mefti and I published that many years ago, where if you radiate a meningioma and you get recurrence, it's a bad actor. They recur quickly. They're genetically changed, and whether that would happen without radiation, because we've seen that obviously with other tumors that they progress along the course over time. But clearly, if you have a failure of radiation, they're in trouble. And we usually use surgery as an aggressive salvage option at that point. So rightly or wrongly, because the patients are running out of treatment options.
Yeah, I think as you know, I like to treat patients with gamma knife radiation if I leave tumor behind, but only if it's possible to deliver a very good radiation treatment. And I haven't seen many problems with that, with magnification. But what I have seen is patients have had lower dose radiation, then I've seen bad things happen.
Right.
With longer follow-ups. So.
Right. We also have a lot of patients here that are childhood survivors of hematologic malignancies, and they've had cranial spinal radiation. And I see a lot of patients these days, just like the tinea capitis series in Israel, that these aggressive meningiomas are often base of the skull. And I operated on one yesterday, in fact. So these are problematic patients as well because they tend to be more aggressive.
Salman, do you have a comment? Would you like to comment? Salman, you are muted, yeah.
Basant, I totally agree. I think that was very, very nice talk. I really enjoyed that. I think what we have learned over the years was very nicely summarized there. And I'm really indebted for such a nice talk.
Sarah, you want to give some comment, questions, anything you have?
Me, sorry. Professor Caldwell, that was amazing. Occasionally these cases come to us, and we initially would ring oculoplastics or ENT, and everyone would just look at us blankly. And so I think, as you say, we've got to embrace this, and this is another thing that neurosurgeons can get into and look further at. So I thought that was wonderful. Thank you.
Yeah. Yeah, I think, this is disease that we operate on all the time. And I find that our techniques in dealing with it, we're much more experienced with these techniques than most of the ocular surgeons are, because they're dealing with different disease completely.
Yeah, I noticed that when I asked them to join me in the case, I thought they would have more idea than me, but it turns out it was the other way around.
Yeah. So. Exactly.
Bill, I got interested because I was working in an institute down south with, but this is very nice, the ophthalmology group there. So in cooperation with that, I got interested in that, and very early on in my career. So we had a large experience there in the orbital tumor. So we used to do all kinds of things. But what you saw today, the more dramatic things, we haven't done that. But I think that is, as you said, that's failure of surgery rather than anything else. So, the first treatment probably was the best treatment you can do it. I don't know whether Isabelle is available or she is in the flight, so I don't know whether she could come in. I think she may be probably. Are you available, Isabelle, for any comments? I think she is still taking off in the flight. Can I just ask the support team if there are any questions, because I don't see anything in the chat. Is there somewhere any questions, support? Pramod?
I have a question, William.
Not there right now.
Okay, fine. So we will go on for the young neurosurgeons, and as I said, Professor.
I just have a question, Bassam.
Yeah, please go ahead.
Yeah, what I was going to ask William was that for young neurosurgeons, when they're starting out these kind of surgeries, what kind of procedures would you ask them to do first or look out for first before attempting heroic, big macho work?
So I think it's important, say if you're operating on a sphenoorbital meningioma, which invariably involves the orbital wall, I have the residents and the fellows drill it all, and learn to drill the involved bone. I think that's the first step. Understand that they can drill and try to leave the periorbit intact and just use that skill set, because that's really the key, is to get the involved bone out of there, because it's a nidus for recurrence. It thickens up over time. And the patients often complain of this engorged eye, and there's a lot of tension. It's very uncomfortable and proptotic. And so I think that's half the key, is having them understand the anatomy and learning to use the drill properly to drill back to normal looking bone, middle fossa floor, get back to the normal bone.
Bill, I just remember the one case I said we did, that optic nerve, which we thought glioma, but then turned out to be solitary fibrous tumor. We actually kept the orbital roof as put it back. We took it as a flap instead of a titanium plate. We put that back. We took that flap rather than drill it out. So there was no artificial thing. That was the bone.
I think that's a good idea. I think it's a great idea, because that's normal bone, no problem, right? Yeah. So
there is one question from Dr. Raz. I see here, optic nerve sheath meningioma. Sam Almaty has talked about it, but your comments with reasonable, good, serviceable vision, your plan.
Yeah, I think that's a tough one. So the traditional teaching, as you know, is that if the patients start to lose vision with an optic nerve sheath meningioma, the ophthalmologists usually send them for radiation, and we'll do that. The only exception I would say is there's a merging of an optic nerve sheath meningioma case to a tuberculum meningioma case, and I don't think the ophthalmologists appreciate this as much as the neurosurgeons, because when you're operating on a tuberculum meningioma, Sometimes it goes down into the canal and involves the dura around the falciform ligament underneath the nerve, and then it's turning into an optic nerve sheath meningioma. So there's a continuum. So the point that I'd like to make is, if I see the nerve is involved with the sheath in the canal, I'll drill the canal. I think that's a surgical indication. If it's beyond the canal in the orbit, then I prefer personally to just radiate the patient and watch them. But I know that this is controversial, that Sam El-Mefti now has published a few cases where he's he's peeled the tumor off the nerve in the orbit. I have not done that myself, but I'd appreciate other people's thoughts. Basant, have you done that?
Yeah, I'm very scared. We are very, very young. When I was very young, I tried doing that with kind of worse vision than damaging the vision. So I have listened to, as you said, Sam El-Mefti's presentation with a lot of interest, but I have not been able to, kind of persuade me to go in and do that, take out an optic nerve sheath meningioma in a patient who has good vision. We have observed, we have a couple of patients, not only, maybe I think 2 patients where we have given gamma knife, and when there is progression of vision with some stability of that, but it's a very, very small number. Most of them, we wait till the patient goes blind on that.
Sure.
Pure, I'm not talking of tuberculum, sorry. I'm just talking pure optic nerve sheath meningiomas,
Right, understood. Sarah?
Yeah, no, I was just thinking, I think the trick with that, and I've learned this the hard way, is you think it's a tuberculum cell meningioma, and you've really got to look closely, and because you've got to be wary before they get into that optic nerve sheath and treat them before that happens. So if it's starting to happen, you think you've just taken out a tuberculum cell meningioma and you haven't seen that extension, then I think that's is very key. You've got to see that early and get onto those patients early.
I think it's really nuanced in that area as to whether it's a surgical decompression or whether it's a no-fly zone non-surgical disease. And I think I'm still learning and from this myself. Teet, I'd appreciate your thoughts.
I agree with that. I share Basant's experience. I have tried to do a very refined microsurgery and peel off, but I've been, after being told by some older senior neurosurgeons it can be done, but I haven't been able to get good results with that. I agree with your observation that I've sent 15 or 16 consecutive patients to colleagues in Germany for stereotactic fractionated radiosurgery with really excellent results on long-term follow-up. No tumor progression and good visual outcome. My experience is really if you see a rapid decrease, if patients lose vision rapidly, I've done decompression with extremely good results with return of vision. I think that makes a lot of sense. But my question to you, Bill, is that the worst outcome of the radiation patients was patient was sent for radiation, and after a year, vision got worse, and all kinds of new basal lesions, contrast-enhancing lesions, started popping up. And in the end, it turned out that our only failure was a patient who had a sarcoidosis.
Right.
How do you view the differential diagnosis of lymphoma and sarcoidosis? Do you need to get tissue, or is there some other way to get around it?
You know, we've dealt with this with the cavernous sinus for years, and I know that Basant and you probably share my experience with this, but we've had lots of cases because radiosurgery is done so liberally in this country. We've had lots of cases where other disease besides meningioma has been treated with radiosurgery. And so I do think, this is not part of this talk, but I do agree with a couple of my colleagues in that we should probably be a little bit more aggressive in younger people to try and take a look with surgery in the cavernous sinus and see if there's something to remove. There was a video I didn't show you here because of time, but some of these meningiomas, for instance, can be very, very isolated and lobular in the cavernous sinus. And I had one in a 13-year-old girl that everybody was saying, just radiate, just radiate. And we did a little orbitotomy and looked at it. And we could just pluck it out like a little pea, and her third nerve got better. So I do think we should probably not give up our surgical principles as much as we've done. Because I've been burned several times too, where we've radiated and then there's been progression, and it's obviously a different disease. We've had lymphoma, we've had inflammatory disease, which is so prevalent in the paracellular area and the cavernous sinus. And there's many ways to fail if we end up treating the wrong disease, you know.
I can't emphasize more than what you said. I mean, that's absolutely important to have the tissue diagnosis in these paracellular lesions, especially in my continent. We would never, ever. I don't know whether Bill would remember, we were actually in maybe it was one of the World Congress. We were in a session as faculty, and I did present one many years back, and a cavernous sinus lesion, which was, we get a lot of patients referred because we were the first gamma knife site in India for gamma knife for small cavernous sinus paracellular lesions. And our dictum is, unless absolutely 100%, we would never give gamma knife unless and we have a tissue diagnosis, and we would follow it up. And that would probably, you follow it up for a couple of years, and then you know that it is not an inflammatory lesion because they don't grow there. And I saw, Bill won't remember, but there was an aspergilloma in a young fellow who happens to be now working in Australia, by the way, whom I had operated, and that was an aspergilloma. We just decompressed, and of course he went on to have 1 year antifungal treatment, and he's absolutely normal. And that would have been gamma knife. That would have been disaster. So I teach all my young neurosurgeons, never ever give radiosurgery. And one of the things which most often helps us is the T2 images. They are dark on T2. You always, that's a query that it is something other than meningioma. So we are very cautious about giving primary radiosurgery for meningioma without tissue diagnosis. I think, Bill, there is one more question to you. An interesting question is how far nasal endoscopic approach addresses orbital lesions, from Dr. Deepak Jha.
So yeah, we'll use them all for the inferior orbital lesions and the medial orbital lesions. The only problem sometimes is getting far enough anterior. It depends on how far you can look up, which is the limiting factor. It's usually the posterior aspect of the frontal sinus we'll use as the guide. But I think it's a wonderful way of dealing with like inferior and medial orbital lesions. I mean, it's great. It's minimally invasive, no incisions. You can use a transmaxillary approach directly too. And we've published a little technical note. You can come in biportal if you want, through the nose, through the maxillary sinus, through a Caldwell-Luck maxillotomy. It's a simple thing to do and a great way to go.
Bill, I have one more question before I go on, because I just remembered that, this patient which we operated while excising the optic nerve, the toto, on the globe side, the globe got opened, so what do you do about it?
So I try not to have the globe leak. So if you come just back a little bit farther.
We tried that, but it accidentally got opened.
That's a problem.
Whether there is some reaction. I had no experience with that. Fortunately, nothing happened. The patient healed and there was no reaction, nothing. So has anybody any experience that kind of thing? What happens if it leaks? Is that
it shrinks up. It's terrible.
So that's about it. No, but sometimes they have this kind of, that sympathetic ophthalmitis of the other side. That was what I was worried about, but nothing happened. I mean, the patient went away. All right, that's fine.
Yeah.
Okay, I think we should move on because we're running out of time. That was very interesting. Bill, thank you very much for educating us. I think we have the first talk by Dr. Al Hussein. As I said, Professor Izzat is indisposed, so he will not be joining, but we will, our faculty with us, will communicate with you. Al Hussein will help you out. So please go ahead and do your presentation.
Okay, thank you very much for this great opportunity. So is it
Yeah, good,
you
good.
can see my slide? Okay, thank you very much. Okay, I'll try to restrict to the instruction. I will stop with the investigation. Then after the interaction, I will proceed with the video and the clarification. Okay, this is a 36-year-old woman presented with a unilateral, gradually progressive diminution of vision in the right eye of 1 year duration. The positive finding neurological exam, just right eye perception of light. And the fundus exam, there is no abnormality detected in her exam. We can see this is the images here. In these images, we can see a lesion in the cellular or paracellular area and its relationship to the pituitary gland and the optic chiasm or the optic apparatus. And this lesion has something, a very thin sheet of enhancement, which is directed in this direction, and the relationship of this lesion to the carotid artery. In the coronal view, we can see the paramedial location of this lesion. It's a cross relationship to the carotid arteries, chiasm. And here, interestingly, we can see this is the optic canal. And this enhancement over the optic canal, maybe this is the location of the falciform ligament. And again, in image number 3, we can see the relationship between the optic apparatus, stalk, which is completely separated from this lesion, and the internal carotid artery. In the axial view, we can see this location of the lesion, which is separated from the stalk. And the CT really didn't reveal the lesion. We hardly see the lesion, and there is no bony footprint. We can see here that this structure, which is anterior clinoid process, appears normal. This is optic canal, relationship to the sphenoid sinus, the optic strut, anterior clinoid process, the foramen rotundum, Vidian canal, sphenoid sinus. So no bony abnormalities. I couldn't detect anything here. So I will stop here for the faculty and the younger surgeon interaction.
Teet, go ahead. Teet, you want to comment? I'm very, very complimentary to Bill's talk. So we'll ask.
Yeah, I thought this was Bill's Bill's case in a way, you know. So this is a slowly growing tumor intradurally. There is visual nerve affection. To me, this is a fairly clear surgical indication. I wonder if I can ask the presenter, what kind of differential diagnosis did you consider here?
Yes, first of all, I consider based on this imaging, I consider this might be meningioma because of its location and this dural enhancement, maybe this area, and it is completely separated from the pituitary gland and completely separated from the stalk. So maybe this is not a lesion which arises from the pituitary gland or the stalk. So I restricted my differential diagnosis firstly to maybe a meningioma, which arises in this area, most probably in the paramedian. Maybe this is the location of the anterior clinoid process or something, or enhancement over the falciform ligament. So this is number one, my differential diagnosis.
So how much workup do you think is necessary to sort of develop a strategy for this lesion?
Of course, beside the radiological investigations, I should do some, and the ophthalmological examination, the full exam, fundus, and everything. We just found that the patient had just a perception of light on the right eye with pale optic disc. So after that, we go to the function of the surrounding structure, the pituitary gland, just to make sure that everything is going on, because there is a hidden structure we cannot see here in the MRI, the suprahypophyseal artery. So I want to understand the function of the stalk and the pituitary gland. So I did a pituitary hormone, and of course I did this, and everything was normal.
Yeah, well, I think it's, of course, one should think of that, but looking at the images, I would be very surprised if there was a pituitary affection. or a
Yes.
functional affection of the pituitary. Another thing that one usually should think about when working in this area is there any, I mean, especially if you look at the axial, is there any risk that we are looking at a vascular lesion of some kind that we may run into?
Yes.
Did you do any,
Uh,
was that ever any differential diagnosis, or did you look at any images for that? Or
here, interestingly, I just a finding. I can see the carotid artery on the right side is slightly smaller in diameter on the left side in the preoperative, especially in the coronal. But really, this patient didn't complain from any transient ischemic attacks or something like that. But really, I didn't do angiography for her.
Well, I mean, I suppose if you look at the MRI, you can see that there is a normal
Yes.
vessel and at the distance.
Yes,
so
yes, yes.
So do you have a differential diagnosis? Do you think that it could be anything other than a meningioma? How old is this patient? I missed that.
This is a 36-year-old woman.
Okay.
But because the tumor was small and associated with this marked visual affection, first of all, I should exclude any thing arises from the optic apparatus pathway, or is it just a compression or ischemia to the optic nerve by this lesion? Especially, particularly, we can see this enhancement surrounding the optic nerve in this narrow area. So I became afraid this is the origin of the tumor. This may be the origin of the tumor surrounding the optic nerve, not from the optic nerve, but surrounding it. But I can see the enhancement only superiorly. So I consider this is a clinoidal meningioma maybe, but the subtype of this clinoidal meningioma, I just, which subtype, I just later on, but I didn't add any differential diagnosis, any other possibilities, because the optic pathways seems to be normal, and the and you can see here the optic nerve is elevated and pushed. So this is the lesion is not arises from the optic nerve or optic tract, and not from the pituitary axis or the hypothalamus. So again and again and again, the restriction.
All of us would agree that this is not a. I mean, there is. It doesn't have any connection to the pituitary gland. It's free. You can see very nicely, and there's no question about it. And I also think, I mean, if there is anybody has a different opinion, please go ahead and tell me. But I don't think there is any differential diagnosis as far as pathology is concerned. It's a meningioma. I don't think that I would consider any differential diagnosis for if my president is presenting, it's a meningioma. The thing which Professor Mathieson talked about is sometimes you can miss a vascular lesion. Of course, not this one, but one has to be careful because they also would look something similar, but the configuration, the outline is different. That dural enhancement won't be there, but in this location, it would be good to have this in the mind that it could be a vascular lesion so that you don't burn your fingers. Bill, you want to comment before we?
I think it's all been nicely discussed. The only other thing that I would think of, and just because I've seen cases like this, is always remember breast metastasis in a woman. Now she's pretty young, obviously she's 36, and prostate in a man can go to the dura. And I wondered if you go back to your CT scan, your bone windows on the CT, there's almost a little bit of sclerosis there on this center image, you know? I'm just wondering if it certainly could be meningioma, statistically most likely meningioma, I completely agree. But there are a few other things that you always want to think about as well. And then every time I see a meningioma in a woman, I always talk and counsel the patient about breast metastasis, just as a teaching point.
Yeah.
Okay, thank you very much.
I think statistically also there is a association, higher association of breast malignancy and meningioma. I think that is correct. And that's the reason I asked actually the age, a little too young for that, but yes, that has to be considered metastasis. Sarah, you want to comment? I don't know whether Isabel has.
No, I suspect we're on to the next bit. And as a young person with visual deterioration, So I think we'd all agree that that was a surgical case. So which way would you operate on this, Al-Hussein?
Yes. Should I continue?
Yeah, but let's ask Salman if you have any comment before that. Salman, you want to ask anything, comment? Is Salman there, or I don't know whether he's off. Okay, so I think you can go ahead and answer Sarah's question. So you see, he can continue the presentation and then he will answer what he did probably. Is that okay, Sarah? Yeah. Go ahead, please.
Because the rationale of my procedure, I selected the transcranial route for this anteroclinoidal.
Hussein, just 1 second. I think all of us would agree that this is a surgical case, like Professor Olson talked about. This is not radiosurgery. I mean, this should not be sent for, though the size is small, this is not a candidate for any form of radiation. That I think we should all emphasize that. And then please go ahead.
Okay, thank you. So why I selected the transcranial route in this patient, because the patient has a precious left eye and the paramedian tumor location, and the tumor origin based on Al-Miftis classification maybe not doable by the endoscopic Indonesia approach. And I want to see and check the circuminfundibular arterial plexus and preserve it. Here, this superior hypophyseal artery cannot be seen in MRI, but I should expect its location. I studied the risk and the procedure and its potential benefits. I draw this preoperative simulation. I put in my mind, this is the tumor location, compressing the optic nerve like this, and the internal carotid artery. In image number 2, the hidden structure, the superior hypophyseal arteries and the circuminfundibular plexus. I should make sure and identify and preserve these arteries. And finally, after removal of the tumor, I should open the falciform ligament and check the optic canal. Of course, the order, maybe some doctor prefer to open it first, but anyway, it should be examined, the optic canal, because of this enhancement. What is the risk? If we include this circuminfundibular anastomosis, the ischemia will occur and the patient will suffer from preserve and remove the compression over this circuminfundibular plexus might be a reason for improved outcome in her vision. I used the supine pterional approach. It is a matter of debate, but I used the methylprednisolone because I will manipulate around a compromised optic nerve. This is my key surgical steps, and I will go now with the video. This is a right frontotemporal approach. I identify the pertinent anatomy first, and I go directly to the tumor base to start the devascularization as a step-by-step tumor removal. After that, I directed my focus to the internal carotid artery. Of course, here we shouldn't dissect from the carotid toward the optic chiasm or the optic apparatus. We should do the reverse. But I already did some debulking, and here I want to check if there is any adhesions to the adventitia of the internal carotid artery or not. The arachnoid was intact and there is no adhesion. And we can see the posterior clinoid process here. And this is a pituitary stalk. This is the undersurface of the tumor. Now I can understand my limitation or my boundaries. I continue try to use microdissectors to roll out the tumor to my removal cavity. Of course, these small kind of tumors didn't need a spatula or retraction, but I will try to use a retraction-less surgery as I'm going later on by time. Of course, here, this is the arachnoid membrane is intact, not violated by this tumor. And after that, we can see here the superior hypophyseal artery clearly. This is superior hypophyseal artery seen clearly underneath the tumor. So I can preserve now, I can know the hidden structures. And after I remove the tumor, we can see part of the tumor of the optic nerve, but it is easily separable. And this is the origin of the tumor here. I try to approach the hidden structures. In the MRI, we can see inframedial to the tumor. So I should check the blind spot, which is the optic nerve. And this is a circuminfundibular arterial plexus. This is a falsified, I call it maybe the anterior petroclinoidal ligament. I used the curved structures to try to remove the lesion from this area. And finally, after I make sure there is no tumor here in this area, using these different methods of dissections and curating this area, I will focus my attempts to the optic nerve. So now maybe it seems nothing of the tumor. Of course, later on, I coagulated this area with a low power bipolar. I focus to the falciform ligament. I should emphasize that the ophthalmic arteries sometimes go above the optic nerve here, so it is very dangerous, but I checked it carefully many times before, and it was safe. I use the cerebral, to avoid cerebral vasospasm, I sometimes use local vasodilators, and here I try to open the falciform ligament and try to check the proximal part of the optic canal. There was no lesion here, and nothing of the tumor surrounding the optic canal. So the patients awoke satisfactory from anesthesia without any complications. I didn't need to remove the anterior clinoid in this case. We tailor it based on the case by case, but I drill the distal wing of noid to make some access. This is the post-operative MRI of this patient, so reasonable resection of the tumor. The enhancement was disappeared. This patient vision improved in post-operative day 3. From just perception of light in her preoperative state, she now can count finger from 50 centimeters on post-operative day 3 and increased to 90 centimeters after 3 months. However, the optic disc became still pale optic disc. And the patient satisfied with this 90 centimeter and is stable till now. Histopathology revealed WHA grade 1 meningioma, and there is no evidence of recurrence.
Very nice. I think we should stop.
If I continue to...
No, I think we just stop there because we need to have a case presentation. Let's not go to the literature because we have many cases to be presented. But just a couple of comments before I give it to the other faculty. I think a very nice demonstration what you said. I would agree with most of it what you said. I would just re-emphasize before you started on the tumor, I would be quite wide opening of the Sylvian fissure to kind of have a lax brain so that you reduce your or don't use retraction. And number 2, I would even if you have cut the falciform ligament and seen that there is nothing, I would still open up the optic canal. I would drill it up and I would make sure that there is nothing inside. That's the only extra thing I'd probably do it. And it would be good to also have an endoscope assistant sometimes that helps. You can do that. And of course, there is a discussion about whether you should drill the anterior clinoid and the optic canal in extradurally in this kind of patients or intradurally. There has been some discussion about that. I don't drill extradural. I first remove the tumor and I go intradural and I drill depending on how much I need to drill. Whereas if I have to do it extradural, then it will be probably sometimes overkill. So that's something which I would emphasize. The last point I would like to make it, before I start taking out the tumor from the carotid dissection and so on, I most of the time I release the tumor base, the attachment, so that becomes almost like avascular. That's something which I do routinely for all skull-based meningiomas. And you nicely demonstrated the arachnoid plane is intact. That's a very good thing. Comments from other faculty, please. Yes, Steve, go ahead, please.
Yeah, nice dissection and a nice video, but I really think one has to discuss the long-term outcome in patients like this. You did nice surgery. You also concluded that there was no need to remove the anterior clinoid in this case. But in my world, the proof is in the pudding in 2 ways. And when we saw the video, I really saw a lot of blind spots, and remaining blind spots. I noticed that the technique one needs to use is sort of a lot of using blunt instruments, fishing for pieces of tumor. Now, thinking of let's say basic meningioma biology, the origin of a meningioma is in the dura and in the bone. And whenever possible, I think we should try to do a Simpson grade 1 removal, which includes removal of the bony origin and of the dural origin. This is absolutely very difficult area to coagulate with enough power to kill off an extensive number of meningioma cells without killing off optic nerve cells while you go along. So I think we should remember that there is some pretty good literature on the strategies of this kind of tumor, and a lot of supportive literature on the benefits of early decompression, opening of the optic nerve canal. If you can decompress the optic nerve before you start dissecting the tumor, you will not need to manipulate the optic nerve as much. And so I would recommend to consider decompressing early with an early removal of the bony origin, opening of the optic canal, and also opening the falciform ligament sharply before you start dissecting the tumor to get even better long-term outcomes. And of course, 13-month workup is fine, but the problem we encounter with these tumors is if you're allowed to follow them for 5 or 10 or 15 years, and you can see the recurrences, which can then be extremely difficult to handle. And the recurrence may come back as an optic sheath meningioma rather than a anterior clinoid meningioma. So nice case, but I really would like to make a case for the more extensive skull base dissection.
Yeah,
Thank you very much.
Professor Kuldwell just taught us how to go about it. I think it's important. I think Dr. Matheson emphasized drilling off the skull base, the anteroclinoid, and opening up the optic canal. That's a very important. Before Bill goes for giving the comments, I just want to ask the faculty, how many of you do extradural, in a patient like this, would do extradural drilling? How many would do intradural drilling? Tito, go ahead. How do you do it?
Well, I've done extradural drilling as part of most opening in this region for years, so I would do that without hesitation.
Okay, and Bill, you would do extradural also? What do you do?
Yeah, I actually follow your philosophy on this, Basant. So I do extradural usually for aneurysms and normal anatomy and cavernous sinus, all that kind of thing. But when the tumor's in the canal, I'm always paranoid about doing an extradural and putting extra pressure on the nerve while I'm doing the drilling. And it may be unfounded because, but what I do is in these cases where the tumor's intimately surrounding the nerve, is I open up, I debulk the tumor, I drill the canal out completely, as Teet mentioned, and try to get all the tumor out of the canal to free up the nerve without too much manipulation, retraction. So that's the only concern I have. So I use your philosophy.
Sarah, go ahead.
Yeah, thank you. Yeah, no, I do the same approach for this as I would for an aneurysm. And I figure it's either retract brain or drill bone. So I think drilling bone is preferable. So drill fairly aggressively to get the anterior cranial falciform, middle cranial falciform very flat. And so you've got a very flat axis and don't have to retract much. I was going to ask Al Hussein, no, I completely agree with you. I don't think even the most aggressive transphenoidal surgeons would address this one transphenoidally. But if it was more midline, which way do you think has a better visual outcome, transphenoidal or craniotomy?
I think for this patient,
This is a special case, but a standard
this special
like
case
midnight.
transcranial route for this patient may be reasonable. But of course, I did some cases which is maybe midline, or when the tumor is only here, just inferior-medial to the optic nerve. It can be easily accessible and good decompressed by the endoscopic approach. However, if the lesion traverses the optic and go up and lateral to the optic chiasm, we cannot traverse the optic nerve. We cannot go beyond any nerve in endoscopic endoluminous approach. So the origin of this tumor cannot be reached, or of course, 100% we will leave a remnant. But if this lesion is between the optic nerve and between the optic carotid arteries, like tuberculum cell meningioma or prechiasmatic sulcus meningiomas, small in size, of course, I will go via the endoscopic endonasal approach in these cases, and I will, if it invade the canal infromedially, of course, I will go and open the canal from the infromedial aspect, and I will make a good exposure to the canal. But never, I can't reach the superolateral approach. Of course, extensive approach can be done, but the origin will still here. And this part here, this falciform ligament, made me slightly confused. I thought that he reached from this side transcranial better, maybe. Yeah. So that's why I selected the trans.
If it could be done both ways, then the transvernal route is thought to have the better visual outcome, yeah?
There are many cases which with report with the that the reports of the better outcome via endoscopic endonasal approach was of meningiomas. It includes another kind of meningiomas, which is tuberculum cell prechiasmatic cystoma something. So I don't have enough information in the literature about the anteroclinoid process meningioma, but maybe, of course, the decompression might improve the outcome. But I'm not sure, because Professor Mifty disclosed that maybe this is ischemic nature, not compressive nature of the visual problem. So I don't have enough data. But
it's another very nice discussion which you have brought up. We'll just go back to that, because I have some strong opinions about it. I'm sure Bill has opinions about it, but let's just stick to this before we go on. We'll discuss that a little. Salman, you want to comment on his presentation? Any questions to him before we address what Sarah has opened the Pandora's box?
Okay. Regarding Sarah's comment, first of all, I'd say that
Sarah's comments, Al Hussein, if you want to tell anything about Al Hussein, then you can go to Sarah's comments. Anything?
Okay, I think Al Hussein, I think it was very nice the way he's done it, despite not taking the clinoid. But I would take the clinoid to make life easier for myself, and also to ensure that there's no blind spots in which you're working. So that's there, but at the same time, I will scope in there through the craniotomy.
Yeah, all of us agree that it would be better to remove the more bone than what is done. Now you can address to Sarah's the point, and then we'll go on for that for some time. We'll spend some time on that point. Yeah, go ahead, please. Salman, go ahead.
Okay. So, yeah, so regarding the, if there is an residual tumor left behind, if you have blind spots, do use endoscope. Feel free to use endoscope. You should have your endoscope ready, even when you're doing craniotomy, to ensure that you look behind with a 30-degree scope to ensure you're not missing out on something. So I think that's essential. Regarding Sarah's point, it's very clear that generally tuberculum cell meningiomas are completely different to clinoid, and regarding surgery of what kind of approach you're going to take. So there are some patients with small tumors that you can do endoscopically, but majority of them with visual deficits with tumor above, as shown here, obviously you need to do a craniotomy. Regarding the point about visual better outcome, there is no doubt if you have got tumor above the optics, you're better off coming from there's pressure from below, just like with adenomas. That is the reason we give better results endoscopically in adenomas. We know exactly where the gland is beforehand, and we know that with the endoscopic approach, you can save the gland as well as have better functional outcome as well for vision as well. Whereas it's not the same for meningiomas. You understand it's a completely different scenario. So we need to be careful comparing vision when it's come to meningiomas versus adenomas.
Sarah, I will just, I'll make a point here. I know what you are referring to, the literature, the publications which have compared, the endoscopic approach to tuberculum. Of course, I know the meningioma. I'm talking of tuberculum cellular meningioma. I'm sure that is what you're saying, that the literature suggests there's better visual outcome in endoscopic, which I don't agree with at all, because this is comparing apples with oranges. The number of patients which were operated through an endoscopic approach with a very selected group. And I would go one step further. I have very strong opinion. This is a meningioma. This is an intradural tumor. Why do I want to go? It's a small tumor, which is tuberculum midline meningioma. It's such an easy tumor, even transcranially. So why do I have to spoil the whole nose and kind of screw it up or taking it out? I can understand. I don't agree with that concept at all.
I like the small ones through the nose. I just don't like the big ones through the nose. They're a real nuisance.
The extradural tumor, chordoma is beautiful. Craniopharyngioma, Peter is beautiful approach. But meningioma, the meningioma, which are easy tumors for endoscopic endonasal approach, is also very easy for transcranial approach. I mean, you don't have to touch the brain at all. It's an extra arachnoid tumor. You need to work on the bone. So I have, this is not the norm. I mean, this is the current, the fashion is endoscopic, but I am the one who does not agree with even the tuberculum, not this one, even the tuberculum cellular meningioma. I would say the transcranial approach is a safer approach, less risk of infection, less risk of CSF rhinorrhea, and I would not touch the brain and take out the same tumor, which they can do it through tuberculum. But let's have more experienced people, Bill and the T, talk about it.
Yeah, thank you. I think you've set the stage for the controversy very well. I think it's an issue in my mind of degrees of freedom. So the endoscopic approach is obviously just through one view. And if you open the head and look, you can see through multiple dimensions, look around. And so I was a really early adopter with removing through the nose. And I did a number of them early on in my career, even with the microscope before we used the endoscope. And I've been burned. If you watch over time, the issue is Simpson grade removal, as Basant has mentioned. So what I do is I certainly do them through the nose, but they're very well selected and they're small tumors. And I agree that the literature doesn't reflect apples to apples comparison. You know, if I teach the young people that when you operate on a meningioma, it's like you've dropped a bag of sand on a hard table and you see it spread and you see little nuggets of tumor growth that are far beyond the edge of the tumor that you see on the scan. And I think this is the problem. It's an issue of trying to get the dura out or cauterize properly in a wide fashion. And you just simply don't have the same latitude to be able to do that through the nose. So, but I agree with you. In older people with small tumors in the center, pushing up on the chiasm, it's a beautiful approach because it's so simple to do. And it devascularizes the tumor as you go in, you decompress. So I've certainly an advocate both ways, but most tubercular meningiomas in my hands are done transcranially just for this reason, because he mentioned that the tumor is over the clinoid here, and you cannot cauterize that or remove that adequately through an endonasal approach. You can certainly come underneath the optic nerve, but you can't come lateral to the optic nerve well. And so it's an issue of Simpson grade removal here. And I would certainly do this transcranially, and most of them are done transcranially because of my experience and being burned on some of them.
Can I ask the faculty, does anyone do them or have a patient group that might do them through an eyebrow craniotomy versus a pterional craniotomy? Does anyone do that for anyone?
Do what? Sorry, say that again.
Do an eyebrow craniotomy versus a Does anybody do that? I mean, I've had a much older man I had to do through a terio, and I did through an eyebrow. He's bald, and I thought it was reasonable. I've got very good vision, but
Sarah, I did quite a few with eyebrow because I spent some time in one workshop with Pernesky, and I was fascinated about it. I mean, this was about maybe about 15, 20 years back, because minimally invasive, the patients, they love it. But the only problem, which I don't do it anymore, I don't do why, because if you get infection there, it's much worse than getting infection behind the hairline, number one. Number two, if you open up, especially the frontal sinus, the closer is a little bit suspect in this approach, in the eyebrow approach, because you don't have a, vascularized gallial flap, which you can put it on a frontal sinus. So a couple of patients, I have patient with CSF leak after that, and one patient got infected. So I don't do it anymore. I have done quite a few of this eyebrow approach because of being influenced by Pernesky, spending some time with him. I don't do it anymore. Maybe I think Bill does still that. Bill
Yeah, I agree with you completely. I don't do it in most cases just for the reason that if you get an infection in that approach, it's horrible. But the other thing that I think about, Sarah, is the angle that you're looking at. So with the frontotemporal, it gives you much more of ability to look over the tuberculum. So now you can use an angled endoscope to look over there. I appreciate that. But you're coming much more flatter along the base of the skull. So you can't look down as much on the back side of the tuberculum, which is a minor point, but it is a point that's involved as well. So, but we use mini terional for a lot of them, but I still use the incision behind the hairline for the reasons that Basant mentioned.
Teet, you are muted. Teet, you are muted. You're muted, Teet.
Yes, sorry, no, I cannot more than agree that if you want to get rid of the blind spots, the orbital incision isn't really optimal. And I couldn't more than agree with previous speakers.
So I think it's a very nice discussion, Cheryl. Thank you for bringing up that point. I think we'll move on because Al Hussein, thank you very much. Very nice case. Yeah, we'll go on to the next. I think is Salman, your gentleman, young fellow. Yusuf is going to present now. Dr. Yusuf?
Yes.
Yeah, go ahead, please.
Okay.
Share your screen. Yeah.
Okay. Can everybody see?
Yeah, go ahead.
Okay, so this is the case of a 54-year-old gentleman who was presented through ER with history of trauma. He was basically riding his car and he was not using his seatbelt as well. There was a car rollover and he was subsequently brought in ER. On arrival, he had a GCS of 15/15. His blood pressure was slightly on the lower side and he had quadriparesis. His lower limbs had no power, upper limbs had good power up till elbow flexion, but he had no grip. Distally, he had index sensations. Now we checked it multiple times and he said that yes, he could feel sacral sensations. So clinically, we categorized him as Asia B. So after airway breathing support and management of the vitals, immediate CT scan brain and cervical spine was done. This is the CT scan cervical spine of the right, mid-sagittal and left side, which is showing bilaterally locked facets at the level of C6-7. And this is the axial CT scan that shows the presence of naked facets and locked facets as well. Apart from that, he also had a scalp laceration and he had a small left-sided temporal fracture. Now the fracture was extending inferiorly up to the temporal bone, but this was just above the upper limit of fracture. It was not going above it. And this was the complex laceration that was stitched and that was present on the left side of the scalp. So this was the MRI that was done as well. So this is the mid-sagittal MR that was showing C6-7 locked facets, subluxation, and hyperintensity within the spinal cord at the level, suggesting the presence of cervical contusion. So I'll stop here and ask the consultants to take over and ask further questions.
Yes, Yusuf, that was very good.
Please
the question, first of all, comes in, a patient comes in like that, has quadriparesis. What would you do? What's the first thing you'd do?
Well, generally what we do is that in order to preserve neuronal function, it is said that you keep the mean arterial pressure above 80 millimeter mercury. So generally such patients happen to be in a state of spinal shock. So we generally give them fluids, and if after administration of sufficient fluids, they are not maintaining blood pressure, then we usually start them on inotropes to keep mean arterial pressure more than 80-85 millimeter mercury, because it has been shown to improve overall outcome. This is apart from the routine management that we do of a trauma patient.
How would you classify these patients? This patient has come in. Which classification would you use for cervical spine fracture dislocation?
Generally, we go through cervical spine injury classification score, that is the SLIX, and we use it routinely as a part to identify whether or not this patient needs surgery or surgery or not. In this case, because this was a translation, that was a 4. Because the posterior ligamentous or the posterior facet injury spinous process were injured, so that was also a 3. And in terms of neurology, because we said that he had intact sensation, so incomplete neurology, so that's a 3. So a total score of 433 makes it a total score of 433 makes a total score of possibly 10.
Okay, what about, would you not use AO classification here?
Yes, we can also use AO classification, but it's a bit hard to remember. But if you do that, it basically comes in either.
Would you use AO classification here?
We can, but I generally use SLIX. In AO, it would come as an F4 because it is bilateral facet injury with locked or subluxed facets.
Salman, you can take the other young neurosurgeons also. You can discuss them also, and then you can talk to them also. Salman, you can involve the other young neurosurgeons also.
Okay. Yes, sure.
Yeah, go ahead, please.
Sure. Answer this. Why would you do an MRI, or would you do an MRI if you've got fracture dislocation?
Anybody else wants to comment? Young neurosurgeons want to comment what Professor Salman Sharif is asking. Al Hussein, Ruth?
Yes, I'm here.
You want to comment what question Dr. Salman is asking?
Yes. Regarding this case, do you will apply something like traction, or you go directly to surgery, or you give some medication as a prophylactic like Solimedrol? Do you have some strategy, the order of these things?
Do you need, the question is, do you need to?
You before shifting, I think Salman, your voice is breaking. I don't know whether it is there is some internet problem there. Dr. Yusuf, would you put a traction before sending for MRI, or I mean, before shifting for
MRI? And if you do, why?
Generally, if it depends upon, because if you're working in a tertiary care hospital where you can get an MRI early, so then I would generally apply a collar and get an MRI as soon as possible. But if there's any delay in MRI,
what collar?
Philadelphia collar. But if there is any delay in MRI, then I would definitely put tongs, because generally it is our practice that we put traction, cervical tongs, in the emergency itself.
Salman, you are muted. I think he has some. Teet, you want to comment something?
Not really. I don't have any specific comments for this case yet. I was waiting forward for how it develops. So.
Yeah, Sarah.
No, not at the moment.
Yeah, Salman, you are on now. You are muted. You please go ahead. Bill, if you want to comment something before he goes forward, Bill.
No, I don't have any comments, and I don't do this. My partners do this type of surgery now, but this is a complicated one, obviously, with the lock facets, and you have to think about unlocking those facets first. So the question is whether you'd use traction or you just take them to surgery.
Okay, so the reason we do generally, because you can get MRI very quickly. So we always get MRI on our patients because it's easily and very easily accessible and available to us. So the reason we do MRI is to know the prognosis. So we use a basic score. Yusuf, if you want to tell us something about this basic score that we use?
Yes, this is a basic score. It was formulated, which is taking into consideration the axial aspects of an MRI scan. So if there is a localized hyperintensity within the spinal cord in cross section, that is the basic 1. If there is diffuse hyperintensity, that is basic 2. If there is hyperintensity involving the gray and white matter, that is basic 4. And if there is complete hyperintensity with microhemorrhages, hypointensity in the midline, that is basic 5. So it has been shown that these basic grades, which is basically an axial representation of an MRI T2 scan, correlates with outcome, with basic 0 having good outcome, basic 2, 3, and 4, 5 having relatively poor outcomes.
Okay, good. So what's the first thing you do once you've seen this CT scan? Immediately, what's the first thing you'd like to do and why?
Generally, in an MRI or CT scan or cervical spine like this, I would immediately put traction in emergency itself. But as I mentioned, the case was a bit complicated in terms that he also had a fracture in the temporal area and a scalp laceration. But yet again, the fracture was down and not in the line of application of tongs. And I don't think a laceration poses any complication to application of traction. So we were able to apply traction, and in the next morning, and the facets were reduced. And the next morning, we did an anterior approach.
Okay, the question is, why would you apply traction as soon as possible? What would that do? Why can't you wait till next day?
Well, we can see that there is ongoing cervical compression, and there is a contusion in the spinal cord. So whenever there is ongoing compression, traction basically helps in reduction, and it will also slightly widen or increase the size of the canal.
Yeah, it's shown that with traction, you can increase the size of the canal, even if you don't reduce by 30% of the canal. So which is pretty reasonable for anybody whose cord is compromised. So it's important that we do that as soon as possible. That's why traction should be done in ER as soon as the patient comes in. Once you're happy, there's nothing else going on. Okay, good. So with this, if, for example, this was Asia B, what percentage of Asia B are going to walk again if they have aggressive therapy and operated immediately?
Well, we know that the results of spinal cord injury are not that great, but with the now multimodality treatment, which includes medical management as well, such as keeping the patient hypertense. And so we know that patients with Asia B will have 1 grade Asia improvement. Approximately 20% of them will have some degree of improvement, at least from Asia B to C.
Actually, it's been shown that you can go up to D in about 20% of the patients. And if you go, it's just the difference of sacral sensation, that the difference from 2% rises to 20% of these patients will go to D, where they will be able to walk again with assistance. So I think it's important that these patients should not be left alone. If the basic score is 4 or 5, then yes, your chances of walking again are dismal, because it's been shown that with 5, none of them would walk again. but with 4, it's still possible. If you have microhemorrhages, then you're not going to walk again. But that's, having said that, 20% is pretty good from 2%. And if you go on to C, then it goes up to that half of the people are going to walk again. So I think it's important that we are aggressive with these patients, especially with complete injuries. So that's the message that we have here, that there's a pretty reasonable chance if you treat these patients aggressively, then you can get there. What do you think about steroids, Yusuf?
Well, most of the data that I have read and I have come across, I think the use of steroids was much more dependent on faith rather than actual evidence. And most of the evidence suggested that steroids don't help much and they have increased risk of complications, particularly those with cervical contusions, because they will be admitted in ICU and will have increased risk of infections, pneumonia. But even speaking with that, I think there is a matter of faith when we still continue to give steroids. I did not use steroids in this case, though.
But Salman, do you give steroids, methylpred, or you don't give now? I mean,
no. There is class 1 evidence that steroids do not work. There is class 1 evidence that they cause harmful effects, including death. So ideally, they should not be used. In some centers where, for example, you're operating in the middle of surgery, something worse happens and your drill hits the cord or something, or if you injure at that time, then yes, that's the time you can give steroids. So for example, your injury happens at the time and in the car you have got a methylpred shot, then yes, it would be a very good idea to get it. But the problem is to know when you're going to have injury is not possible. So in theater, if you do something dismal or worse to the patient, then that is the time to give steroids, but otherwise it's not indicated. And in fact, it causes serious problems. The only place we use steroids, if somebody has got C7T1 injury and you've got, your fingers are not moving, your palm is not moving, in that case, you could use steroids, because the evidence is if you use steroids, you can go up by 1 level down. And if you do that, then there's a chance that their fingers and hands are going to be functional later on. And that too in young people without risk of any chest or any other tummy issues. So you don't want to be giving them other issues that could be a problem secondary to giving steroids, because these steroids are high dose steroids. So you're talking about 2 grams of steroids of methylpred given over 20 minutes. And then you have got that maintenance dose that you can give up till 8 hours or 12 hours, depending on whichever faith that you follow. But having said that, we have seen really they do not work. What works is if you bring the pressure up, you keep the pressure up, you aggressively manage these patients, you operate as soon as possible, and you make sure your anesthetists know what you're doing and they understand that pressure is so, it's like a religion for you, it's like faith for you. It's very important that keep the mean arterial pressure above 85. And there is level 1 evidence to show that everywhere. This has been going on since 1970s. When these came out, and we know the guidelines clearly say that you should work towards blood pressure, making sure that it's appropriate, and at the same time decompress early and are aggressive in any kind of treatment that you do.
I think Bill, I don't know, Bill, were you there in the American Academy meeting, which there is this, I think is the Canadian trial of this early decompression versus late decompression? The early data was quite promising that the early decompression does help. And this was in the American Academy meeting this time, which was done virtually. He just presented the preliminary data. I don't know whether it has been published yet. I don't think it is published. They're going to publish it, but that was promising.
Yeah, that was Mike Failing's work. Right. Yeah, they're demonstrating, I think within 12 hours was the better outcome, right?
Yeah, Salman, the question to Yusuf, you operated the next day. Why not the same day? Why not the same? I mean, did it come in the night, or what is your protocol? When do you operate next day? And when do you operate the same day in an injury which you have decided to operate, decompress and fix?
Generally, when these patients present to us in the morning, then we operate them as soon as possible in the next few hours. But because the patient came at night, so we operated the first thing early next morning.
Okay.
So There are clear guidelines regarding that. And yes, Mike Feelings has published about 10 different papers on the timing of surgery. We have also published a little bit on that as well. And we all have shown that if you operate within 6 hours, that's the best time. The cutoff time is 6 hours, the best time, but generally 12 hours is recommended. Beyond that, obviously the results change, but we have seen that you can improve up to 2 grades if you operate within 12 hours, compared to just 1 grade if you operate after 24 hours.
Yeah, I think the American Academy, this was a multi-centric study, which I don't know if it is in published, but I heard it online when the virtual meeting, and it was impressive. Any other comment?
The initial first 2 papers were 6 months and 1 year, and now there's a follow-up to that.
Yeah. Yeah. Any other comment from young neurosurgeon faculty before we move on to the next one? I don't know whether Isabel, I don't see her there. I don't know whether she's available, but Sarah and any other young neurosurgeon you want to comment anything before we go on to the next presentation? If there is nothing, thank you very much. This is something which is useful for me because I don't do these cases, so it is educative for me. We go on to the next talk by Dr. Ruth Missel, who is actually a Nobel Peace Prize winner of 2017. Maybe she will talk about that a little bit in at the later part of her presentation. She is going to talk on skull base case from Melbourne. Ruth, please go ahead.
Thank you. Thank you very much. It's an absolute honor and a delight to be joining you. I'm coming to you from the future. It's already Wednesday here in Melbourne. So I'm here to tell you that Wednesday is going really well so far. I want to start by acknowledging that I get to live and work on the beautiful land of the Wurundjeri people of the Kulin Nation. I pay my respects to their elders, past, present, and emerging, and I find it really very important to always address the traditional owners of the land that I live on, especially as we try to reach greater health equity in our work. I want to share with you a story of a patient we managed recently. He was a 62-year-old farmer. You can imagine that these are his kangaroos in the field, if you like, in beautiful rural Victoria, near where I live. He'd had several years of gradual visual loss, and he also complained of low energy levels. He was referred to a specialist neuro-ophthalmologist when, after many years of getting glasses that didn't fix his problem, he was noted to have an RIPD. The neuro-ophthalmologist assessed him thoroughly and found that he had a right visual acuity that was 6/6, completely normal, and a left visual acuity of 6/36. Fundoscopy showed left optic atrophy, and he also underwent optical coherence tomography. And this confirmed the left optic atrophy with extensive thinning of the retina, but he also had subtle right retinal nerve fiber layer thinning. And this, alerted the neuro-ophthalmologist that there might in fact be a chiasmatic problem. The patient had an endocrine workup at this point, which showed a very slightly low testosterone, but no other abnormalities whatsoever. And then he had this MRI scan, and here we can see clearly demonstrated a number of very obvious gross findings. And most notably, there's this large, relatively homogeneously enhancing lesion throughout the pituitary fossa, extending superiorly, supracellularly, and also posteriorly. And on the coronal views, we can see that this is more left-sided than right-sided, but this appears to be a lobulated lesion and very, very significant in size. On the T2 imaging, it becomes more apparent the relationship of this tumor to this lesion to the both the vascular structures and also the optic apparatus. And this certainly accounted for this patient's significant left-sided visual deficit and also its time course. So that's how the patient presented and how they were investigated.
Thank you, Ruth. So
I'll pause there.
You've done all the workup. You've done the visual acuity. You've done the OCTs that are common in Melbourne, looking to see if there's any threat to vision on the other side. And you've done the endocrinological workup. So if you're looking at that, is that a straightforward adenoma? Are there a few things you might looking at that might be concerning there?
So although the enhancement pattern looks pretty consistent for a macroadenoma, the shape and the distribution of it are concerning, certainly in terms of the approach to the lesion. You know, I think that a smaller lesion confined to the pituitary fossa would seem a much more straightforward case for a transsphenoidal transnasal approach. So I would have concerns about approaching this. Certainly, you'd be hoping it would be nice and soft in consistency, but they can certainly be otherwise. So those would be some of my concerns. Also, the close association with those key vascular structures is also something to plan for.
Yeah, I agree with you there. And if you look at that sagittal, I mean, I'd be concerned this is multilobulated. They are always far more tricky than just a standard adenoma. And its posterior extension is potentially problematic. So I think, as you said, I think you warn the patient that if it's all nice and soft, then this is likely just going to be one operation and very easy. But if it's firm and stuck, then, potentially they could be looking at more than one operation. Where do you think the optic nerves are amongst all of that?
So I think that they're been displaced superiorly, as has the chiasm, by the suprasellar component of this lesion.
Do you think that posterior bit might come up between the tracks, or is it?
I think that's entirely possible. I think it might be sort of just behind the chiasm, just behind the sort of as they bifurcate going backwards.
Lovely. Yes, I think that's what worries me is the multilobulation, the posterior extension, that this could be a lot trickier, especially if it's very firm. Has anyone else got any comments there?
Is there any differential diagnosis, Ruth? Or are you considering any differential, or this is just one differential?
So I think this patient, that most likely this will be a pituitary macroadenoma based on these appearances. It would be very unusual for this to be something such as a meningioma or something like that. But of course, you can never be 100% certain until you've got histopathology.
Any more comments about the imaging? Would you like to comment anything more about imaging in description? Or anything else you would like to emphasize? Can you see the normal gland? Are you seeing the normal gland anywhere? Are you seeing the posterior pituitary?
So
we look for that posterior pituitary bright spot, but I couldn't see it. Could you, Basant? I couldn't be sure where it is.
No, I don't think. I think, but there is normal gland. I think the gland is pushed. There is pushed normal gland and compressed normal gland on the left side.
Yeah, I think you're right on that coronal. Now I see it.
I think the tumor is still extra cavernous because the tumor, if you see there, this is the carotid artery. I think the tumor, as you rightly pointed out, everything would depend on the consistency. I think there is some gland, normal gland here also. This could be part of the posterior. I'm not sure about it, but there is normal gland. So one should, kind of attempt removing the tumor and having normal pituitary function. The concern, as you have already pointed out, is the posterior lobulated thing with it. But I suppose this would come out in the endonasal procedure. I think this should come out once you take it out. Though this cut you are seeing, this probably is continuous because this may be, sectioning and there is a partial voluming there. I don't think there is a gap between these two. I think this is just picking up part of it. So I think it is just continuous. Once you decompress, you should be able to do it. That's what it would be. But I think you're right. The significantly depends on the consistency of the tumor.
It is indeed continuous when you're able to scroll through all of the stack.
Yeah, T, Bill, Salman, you want to comment? Anything else you want to comment on this? Any young neurosurgeon has any point to make?
Excuse me, if possible, can I ask one question?
Please go ahead. Just I don't know who is
this is Al Hussein Najm.
Yeah, please go ahead. Yeah.
In these sagittal images, we can see an enhancement in the lower edge of the tumor at the level of the sphenoid sinus.
Yeah.
I'm not sure if it is a vein or a tumor or the normal pituitary. Have you done a dynamic study to exclude this is a stretched downward trajectory faced the pituitary gland?
We didn't. I think most of us thought that probably was the pituitary gland. And the reason why we didn't do an additional MR scan was because his visual acuity was so bad. He comes from the countryside, and we're only able to do, at the time when this case was booked, we were only able to do high priority cases because of COVID restrictions, and getting access to scans and getting him in from the country. And, the amount of time he had to quarantine after he had a COVID swab and all this sort of thing meant that we had to make a decision that what we had with this image was adequate to do what we needed to do. So I think that under different circumstances, last year, we probably would have done that as well.
Let me ask Dr. Al Hussein and Dr. Ruth, how would you change your management? Would you change your management? In my country, I'll tell you why I'm asking that. In my country, most patients have to pay from their pocket, at least part of for their treatment. So we are very, very cautious about advising investigation again if somebody has already done one. So how would it change? Now, let me put that question to you, both Dr. Al Hussein and you, Ruth. You said last year you would have done it. What would make it, how would it make your management? Would it differ? It would change?
Yes, sometimes if we try to traverse the gland, the function will be affected maybe. So in that time, we should think about traversing the gland. Is it the shortest approach, cutting the gland itself, or shift it to one side? So we should know, maybe the approach will be still endoscopic, but how I can manipulate the gland safely to avoid any post-operative hormonal replacement or panhypopituitarism, because the patient cannot afford the long-term replacement with hormones. Sometimes they cannot buy, and we cannot that they will continue on medication for a long time. So we should preserve their function as much as possible. And we should respect the gland.
The function. What I'm saying is that's pituitary gland. Now you do a dynamic scan, you see that's the pituitary gland. What would you do differently than if you did not know from this much investigation is there and you do a dynamic? This is for Indian perspective. I'm talking from Asian perspective. It's very, very critical for them to, have one more investigation. Sometimes decision between getting treated, not getting treated.
Okay, the treatment the surgical indication may be still there, but the only...
when you open it up, I would not, if this is all that is there, MRI, doesn't matter what time it is, COVID or no COVID, I'm not going to do another MRI for this purpose. That's one of... Ruth, how would it change your management anyway?
So no, and I think that one of the things we're learning is that the restrictions of COVID have probably helped us to think more clearly about what we really need for our patients and what we can change and what we can adapt. So I think it's perhaps one of the very small silver linings to the restrictions that we've had on our health system here in Victoria. For a long time, we have thought that we need to see all of our patients in our clinic, and sometimes they're coming 400 kilometers to see us in clinic. And, for rural pensioners, that can be a very significant imposition. And I think that because we now have ramped up our ability to perform telehealth, we are now able to serve our rural patients far better because we've let go of a dogma about what they need and what they deserve. And we've actually started making it so that our care is more purposeful. So it is, I think, one of the silver linings, very small, but I hope we can hold on to that.
That's correct. I agree completely. Same problem in India. We have long distances. The patients travel, huge country. And that's a revelation, actually, how many patients we can do teleconsult and get away with it. And the patients are so happy with that. So, any more comments from faculty? Bill, Teet, Salman.
I just have one question. I must have missed it, but did you show the endocrinology results already?
Yeah.
Or?
Yeah, yes, almost entirely normal, very slightly decreased testosterone, but everything else was normal, including the prolactin.
Okay, thanks.
Bill, you have anything?
No, I have no other comments. We would just operate on this transnasal. Yeah.
Yeah. Okay, please go ahead then. Ruth, go ahead. What did you do and what
Thank
was
you. So the management we undertook, our operative approach was we work with a combined ENT and neurosurgery team, which I've been learning from this year. We did a transnasal, transsphenoidal endoscopic approach. We had stereotaxy as a backup, but did not depend upon it. The nasal septal flap was preserved, elevated, and sort of retracted inferiorly and protected. The pituitary floor was opened, removed, and opened quite widely, and including more superiorly than we ordinarily would do for a simple transsphenoidal pituitary lesion. The dura was then incised sharply, and immediately quite a lot of macroadenoma-like looking fluid came out. And so that was then removed, under direct vision with the endoscope. With blunt curettes until there wasn't anything else that could be clearly seen in the cavity. At that point, the diaphragma collapsed into the sella, and so the remainder of the curetting occurred with that being elevated. At the end of that process, including resecting right to the edge of the left cavernous sinus, which did not appear to have been invaded, we made the decision to open the arachnoid sharply in the diaphragma so that we could actually inspect and see if there was anything on the other side of that membrane, and also to directly inspect the optic apparatus. So this is what we first saw. So inferiorly, you can see where the pituitary fossa, where the gland is sort of posterior to that, and where the macroadenoma used to be. In the middle of the screen, you can see the cut edge of the diaphragma, and superiorly, you can see the left optic nerve. So coming in slightly more closely, you can see there the left optic nerve and the left carotid, and then the left optic obviously going towards the chiasm. And the reasons to open here were first just to double check there wasn't any tumor that was visible on the inside, but also to allow us to manipulate that slightly and make sure there was nothing posterior to the chiasm that hadn't fallen down. And we wanted to be able to directly inspect the optic apparatus to ensure that particularly that left optic nerve had been well and truly decompressed. And that was the case. So at that point, we repaired the craniotomy that we'd made with a dural substitute. So a suturable dural substitute was placed inside the sella up against the defect that we'd made in the diaphragma. The vascularized nasoseptal flap was laid down over the whole defect in the front of the pituitary fossa. And that was reinforced with Tissile, Surgicel, 2 nasopores, 1 in each nose. And we also had a Foley catheter that we inflated under direct vision under endoscopic vision into the sphenoid sinus. So this operation actually occurred very recently, basically 2 weeks ago. So the long-term recovery is not yet known, but at this point we can say that with the packing out, there's been no CSF leak. There has been a gradual improvement in the vision in the left eye, which is really pleasing. It's improved 1 line on the chart, but it's early days still, and you can never be confident that you've had a good result until the patient is completely recovered and has had long-term follow-up. Just before moving on, just want to say thank you to the 2 surgeons who've taught me so much about these approaches this year. Ian Wang, neurosurgeon, Ben Dixon, the ENT surgeon who we work with, and also really want to say thank you to Dr. Sarah Olson, who is the president of our Neurosurgery Society, for asking me to contribute to this session. It's incredibly enriching to be a part of it. Thank you.
So let Teet go first. You want to comment, Teet?
Well, I think this is really a straightforward case which has been treated by the book. So it's hard for me to add very much to it at this moment.
Nice job, Ruth. Excellent. And a good verification of removal by opening in the arachnoid there.
I don't know that Isabel. Salman, you want to comment? Is Salman there or you have gone away? Salman, you are muted if you're there. No, I think he's not there. But I'm sorry, but I have a little bit of we see very large tumors. I see that you have electively opened the diaphragm. We don't do it. I just wanted to ask you, when you opened the arachnoid and saw, did you see tumor going inside the arachnoid?
No.
Yeah. I honestly, we don't do this. We routinely, very rarely would do a elective opening of the arachnoid and have a nasoseptal flap. We don't do that, but I see that the very experienced surgeons, both Professor Kuldwell and Professor Mathisen, probably do that. So this is something different. We don't do it. We don't do it. We use everything else, but do not electively open the arachnoid and do a nasoseptal flap. Nasoseptal flap for tumor like this pituitary is an uncommon thing which for us. We do a nasoseptal flap for other things, but mostly not for pituitary.
Yeah, I agree with that, Basant. We don't do it for routine pituitaries either. We do it for extended transfernodal openings and other pathology. But for routine pituitaries, we don't do a nasoseptal flap. It's a lot of surgery on the nose, and our leak rate is fairly low, just using other traditional techniques. I think it's not. I think it's okay to open the arachnoid in this case. In general, what he's referring to, Ruth, is that you avoid a lot of headache if you don't open up the diaphragm, because if you're lucky enough to remove the tumor and not have a leak, then you're complicating your life a little bit more by opening it up. But I think it's reasonable on this case because you've got a multilobulated tumor and you don't know whether you're leaving a lobule behind. And I appreciate that.
Yeah, I think when we got to that point, we genuinely couldn't say, well, we've definitely got it out. Like, we're really confident that we've got all of it. What if there's a chunk sitting right behind the chiasm, and this guy's vision doesn't get better? That's not going to be a good story. So we want to make sure we've proven that we've decompressed that nerve.
Okay.
Just ask people, if you haven't got a leak in a standard transfernodal surgery, do you pack it all? I'm always bothered. Like, I love using intracellular fat after talking to Andrew Kay. It saved me a lot of times, but it really messes up my post-operative imaging. But if they haven't got a leak, it really annoys me if they stand up the next day and then they've got a leak. Would you patch in any way? Or do you just reconstruct the cellar floor? I mean, I don't use dural substitutes anymore. I like the fat, which was Andrew's. It was a big advocate of that, and I think it saved me a lot of times. What do other people do? What do they use?
Go ahead. Teet, Bill, go ahead, please.
So if we have a small opening and no leak, we don't do anything. I don't put anything. I just put some Surgicel there. If we have a bigger opening, like in a case like this where you've got herniating diaphragm, I put fat in to protect it because I worry about them sneezing or falling the next day and then having a gush. So we do that to protect the diaphragm or the arachnoid coming down and drying out and breaking. But I use fat for closure for most transfernodals where we have CSF leaks, and our leak rate is low. And I've done that for years. And it actually, if you wait 6 months, I don't scan them for 6 months. And if you wait 6 months, most of the time the fat's gone away. So it's there's nothing that's obscuring your imaging. So that's how I like to do it.
So you put it intracellular like Andrew, yeah?
No.
Put it like a little blast plug?
No, like you can do that, but I always worry about causing taking out a pituitary adenoma and giving them a lipoma against the chiasm. So I fill the fat in the sphenoid. And I close the sphenoid face, because on these bigger tumors, that's the way I usually do it. So we take a golf ball sized piece of fat and then carefully pack it in there, but not putting too much pressure to reproduce the effect on the chiasm.
Basant, what do you do, Professor Mishra?
I think is okay. I'll go first. Teet, you are muted. Teet, you are muted. Okay. So if I have I mean, as I said, unfortunately, we see a lot of patients who are very late, and so multi-compartment big tumors, large macroadenomas. If I have decompressed a large macroadenoma, even if there is no leak, I still put fat. One of the reasons I do it is the fear, which is very unusual, but the fear that there would be, you know, kind of the empty cellar kind of thing, and there is a traction on the optic chiasm and producing a deficit, very theoretically possible, but that has been taught to me 40 years back, so I still do it if it is a large tumor. If it is a small tumor and there is no leak, I don't put anything. But if there is any leak at all, unlike Bill, what he said, I would put fat. If there is a drop of fat, leak, I put fat always. But again, like Bill, I pack this sphenoid sinus. But if I'm packing this sphenoid sinus with fat, I have to take out all the mucosa, because sometimes they can produce a, you know, kind of a mucocele which can get infected. They produce headaches. So if I'm packing fat, I take out this the mucosa from this sphenoid sinus. Yes, if there is a leak, I pack with fat. Extremely unlikely, unusually, I do what you have done, like putting a few cases, maybe handful of cases in macroadenomas, when I put a Foley's catheter to pack the fat and keep it there, especially when there is a large tumor and there's a big empty space, and plus also when there has been very bloody tumor, you know, sometimes we put that as also a hemostatic thing. So about maybe over a period of 30 years, maybe 10 cases of less than 10 cases where I put a Foley's catheter, but fat more often than otherwise. Teet, you are still muted, Teet.
Yeah, I can see I'm muted, but no, I mean, there are different ways to skin a cat, but with the service that we have, one thing is I don't do a whole lot of transsphenoidals, and I think basically I would agree with Bill, and it's dependent on what it looks like, and if you have produced a leak. If you have produced a leak, I mean, obviously you may need to put fat in, but not otherwise.
I always worry about those ones that don't look like they've got one when they're lying down, and then they stand up the next day and you realize you've got one. But I mean, they aren't common, but it's just a real nuisance. And you think, how could I have avoided that?
Sarah, honestly, in my earlier part of my career, it was a standard routine, like what Andrew says, that every patient used to have fat there. But I have a little moved on. I don't put fat now. Now because the vision is much better. We are using endoscope, and you see that there. If your lights are much better, you are definite that there is no leak and it's not a huge tumor, I don't put fat. But if there is any leak or if there is any doubt, I don't hesitate to put fat there. And the fat is the primary closer.
I think the discussion illustrates very well what Bill said at the start of his presentation, that we are really craftsmen when it comes to this kind of issue. And in the beginning of training, we follow rules, and we usually say that the pupil knows the rules and the master knows the exceptions. And I think this is the way we develop surgical expertise and experience. And we need to be confident when you do the surgery. And when Basant is confident he does the right thing, he does the right thing, as does Bill. And with the experience these people have, there is actually a lot of experience behind it, even if it doesn't look like class 1 evidence. I think this is a very important point.
Any other comment? No, thank you very much. Ruth, would you just take a couple of minutes on your Nobel Prize for our interest and for viewers' interest? Let's hear about it.
Certainly, no problem. When I was a medical student, I joined an organization called the Medical Association for the Prevention of War. And I found there mentors and colleagues and friends who wanted to try and make the world a safer place for all of the humans. I got involved with the International Physicians for the Prevention of Nuclear War, IPPNW. And at the same time as I became an intern, I became the deputy chair of their board. As a medical student, as a junior doctor, we launched a campaign called the International Campaign to Abolish Nuclear Weapons, ICAN. So that was in 2007. And in 2017, we were the main civil society partners that negotiated a treaty through the United Nations to ban nuclear weapons, because every other class of weapons of mass destruction are illegal in international law. But up till that treaty, nuclear weapons were not illegal. They've always been immoral, but 2 weeks ago, that treaty hit 50 countries signing it, which means that 2 days after Joe Biden inaugurated, that treaty will come into force. And it is for that treaty that we won the Nobel Peace Prize in 2017. So I think it's an extension of my belief that as doctors, our best work is prevention. And for some problems, there is no cure, there's no treatment, there's only prevention. So it's very intertwined with my philosophy of medicine and surgery. Prevention is first, and prevention is better than cure. So that's the story of my Nobel Peace Prize.
Thank you. That's a pleasure to have you with us. And thank you. Really, it's a privilege to have known you and listened to you. Thank you.
Thank you so much. Thank you. I really appreciate it.
So we go on to the next talk by Hazel Shoera. I don't know whether Isabella has joined us till now, but again, anyway, go ahead, please.
Hello, everybody, and thank you for having me. So I'm going to shift gears a little bit. Let me start my presentation here and share it. Can you see my slides?
Yeah.
All right, perfect. So my name is Hazem Shoera. I am one of the faculty at Mount Sinai Hospital, and we have a partnership with Elmhurst Hospital, which is a New York City Health and Hospitals medical center. So I'm going to talk about a case where we performed fill embolization of a cerebrovascular lesion, and I will use that as a little segue to talk a little bit about working in an underserved population. So the case is of a 40-year-old male with history of fatty liver disease, but otherwise pretty healthy, who had his first tonic-clonic seizure while abroad. He was in the Philippines. Over there, he underwent non-invasive evaluation with a CAT scan, an MRI, an MRA, and an EEG that happened in a staggered way. Initially, he was started on Keppra and was advised to get a catheter-based cerebral angiogram. Not going to reveal what those studies have shown yet, but in the period where he was still waiting in the Philippines, he had 2 additional recurrent seizures. One of them was status epilepticus, all within 1 month, and his AEDs were broadened. When he was told about all his conditional details, he decided to come back to the US to undergo his catheter angiogram here. When I saw him, he reported additionally some headaches, but denied any infections, fevers, or trauma, and his neurological exam was largely intact. So these are some of the images and the evaluations that were done in the Philippines. On the left side, we can see an MRA, which is largely unremarkable. On the right side here is the T2 series of his MRI. I'm going to scroll through it again, maybe a little bit slower. That was the investigations that he came to see me with. And maybe I can take a minute or two for discussion before we move on.
Yeah, T, do you want to comment?
Well, I'd like to ask the presenter to describe the slides and what you find abnormal in it.
Sure, yes, my apologies. So what was abnormal here is the presence of those flow voids that we can see on the T2 that seem to be tortuous and quite extensive in their nature, all following the salsal pattern and even like going into deep areas of the basal cisterns. And they seem to be associated with a region of flare signal change in the bifrontal, more on the right side lobes. So that was the concerning finding.
Yes, and what kind of differential diagnosis would you consider with this with these images and the history?
Yeah, the main thing we were concerned about with the visualization of such congested venous structures is some sort of a shunting. Now, we couldn't see any intraparenchymal nidus of an AVM or what have you, or something of that nature. And so the concern was mainly for an arteriovenous fistula, probably a dural arteriovenous fistula.
Yeah.
What about the sinuses? Did you study the sinuses, the venogram? Were the sinogram done?
So he did not have a venogram, no. The only way we, at that point, when we were evaluating him for the first time, was to be able to look at the flow voids on the T2 and also look at the T1 for any signal change in the sinuses that would suggest the presence of a clot there. But that would absolutely be another consideration is venous sinus thrombosis, although the presence of the congested venous structures probably suggested a little bit of a longer course than one would expect from venous sinus thrombosis, but that was absolutely something that we were considering and looked at.
So what would you do? I mean, let's ask the other young neurosurgeons. I mean, you know the case. Ruth, what would you do now? Ruth, you are muted unless and you've gone to sleep. I know it is Wednesday now, or what? Thursday now. Okay. Ruth, what would you do for this now?
I'm so sorry, my connection just cut out there. What was the...
Okay, so maybe if you have not heard about it, Yusuf, you want to comment? What would you like to do? What is the diagnosis and what would you like to do? Yusuf, you are muted. I think they have all gone. JP, are you there? All right. Okay. Then I think they're not. Al Hussein is on. Would you like to comment? What would you do next, Al Hussein?
Okay. Thank you. I think I'm not sure there is a watershed shift area of here seen in these images T2, which is left right frontal area, and I'd like to proceed with angiographic studies to better understand what is going on and make it a slow arterial phase and the capillary phase and the venous phase, so I can understand what is going on. So I'd like to do angiography, 4 vessels angiography.
So digital subtraction angiography.
Yes, yes, digital subtraction angiography.
Okay, Hassan, just go ahead, please. What did you do?
So
Sarah, would you like to comment, Sarah, please?
No, just thinking. I mean, when I was just finishing, I say when you've got this situation and you can't see a nidus, always think dural AVF. So maybe we're linking maybe 6 vessel angio, yeah?
That's a 6 vessel. That's absolutely important that you do the external carotid circulation also. Absolutely, yes. Please go ahead.
Absolutely. So we took Yusuf and Sarah's suggestions and we proceeded with a 6 vessel angiogram. I will show the key features of the angiogram. So here we see the right external carotid. So I'll point your attention to a few things. Now, obviously the pathology that is clear here is the presence of an abnormal fistulous communication between the middle meningeal artery on the right side, and this venous pouch that communicates with the superior sagittal sinus. Some of the features of that communication is that we see retrograde flow into the anterior 1/3 of the superior sagittal sinus, with evidence of cortical venous reflux on both sides, really, that you can see here. You can see it on the AP, the anterior posterior projection, where you see the cortical venous reflux into both hemispheres. Very robust and congested here, and I think that explains the hypervascularity that we saw on the MRI. And then you can see that it is under such high pressure that it eventually communicates with other parts of the venous system, including the deep venous drainage. You can see here the straight sinus, the great cerebral veins, and so you see this extreme pressurization of the venous system. We proceeded to do a left external carotid angiogram. Where you could see pretty much the same pathology with an even bigger arterial feeder from the left MMA, the left middle meningeal artery. And another feature that was interesting here is the presence of that area of stenosis right at the point of fistulization. You see that superior sagittal sinus has that waist-like narrowing, which is a feature that sometimes is seen in dural arteriovenous fistulas and carries a higher, a worse prognosis in terms of symptomatology and the potential for complications. And then the interesting thing is what we also saw on the internal carotid angiogram, and I'm only going to show one of them. But here you could see that the venous drainage is essentially sparing the anterior segment of the superior sagittal sinus. There doesn't seem to be any anterograde flow. There's no visualization of the anterior superior sagittal sinus in the normal venous phase at all. Instead, you see the cortical veins being congested and having found their collateral pathways through other parts of the venous drainage, but not even the deep venous system. Even the deep venous system is not visualized here. And I don't have the vertebral angiogram in this slide deck, but even in the vertebral angiogram, you could not see the deep venous system. So it seems like even the deep venous system has been quite pressurized. So the diagnosis obviously is a dural arteriovenous fistula. Now the two common classifications that we use are the Conyard and the Borden classification in this case, because the fistula was into the venous sinus with cortical venous reflux that classifies it as a Conyard type 2A plus B. And the question now was, how do we treat this? And I can take a few minutes for discussion of that.
No, you go ahead. Go ahead. I think because you go ahead, please.
Okay. So we decided to proceed with transarterial embolization of that lesion, which in this day and age of liquid embolics is become really the mainstay of treatment of most of the dural arteriovenous fistulas. In this case, the objectives that we kept in mind is that we wanted to penetrate into the fistulous connection and try to make it into the venous outflow of it so that we can achieve cure, as well as preserve any functioning venous structures. Obviously, there are parts of the venous system here that have been reversed in flow and are non-functioning anymore. We also wanted to avoid any complications related to ECA, ICA collaterals, which is just a general principle of transarterial embolization of MMAs, or obviously any supply to vasa nervosum, especially in this case of the facial nerve, if we would take the MMA pedicle. So here you see on the right side the angiogram of the left ECA. You see the MMA, and on the left side you see the balloon catheter that we used. We used a Scepter super compliant balloon, 4 by 10 millimeters, and we navigated as far as we could in that tortuous MMA. As you can see, there was areas of kinking in the proximal anterior division of the MMA, and so the catheter was not navigated beyond that point. That was the maximum point that we were able to take it safely. And then we used fill. Fill is a relatively new liquid embolic agent. It stands for precipitating hydrophobic injectable liquid. And that we'll talk about it in a couple of slides a little bit more, but it is with Onyx, the two main liquid embolics that are used for the treatment of dural AV fistulas. Here we can see fill being injected, and it has this toothpaste-like pattern of penetration and viscosity, which makes it a little bit easier to control when we're trying to achieve deeper penetration. And on the right side here, you see the final cast that the fill has produced, obliterating or occupying the fistulous connection with some reflux, obviously, into the parent vessel. And here you can see our balloon. So the fill has filled the vessel from the balloon to the fistulous communication. To confirm, we did a post-embolization angiogram, which revealed obliteration of the fistula. We also did controlled angiograms from both common carotids and the right external carotid. For the sake of time, I'm not going through those, but they all showed that the fistula had no immediate residual at that point. And this is a before and after picture of the fistula. So as he was emerging from the procedure, he had a seizure. He actually went into status epilepticus as he was emerging, which drove our heart rates a little bit high. But notable is that even when he was undergoing his diagnostic angiogram, he had a seizure. He was having frequent seizures. So we controlled his seizure. We kept him intubated overnight, but then eventually he was extubated with no complications. His neurological exam was intact afterwards, and he had an MRI that didn't show any injury. And then he had an MRV around day 5 as well, which I'm showing here. That shows no residual filling of the fistula still, with preservation of all of the cortical veins that were functioning and the posterior aspect of the superior sagittal sinus. He was discharged home neurologically intact and has not had seizures since then. But I want to take that case to just go over.
Wait. Yeah, what's the follow-up? What's your follow-up now?
So he's currently at 1 month.
1 month, okay. Now, let me take some questions first. What's the etiopathogenesis, do you think, of this patient?
Sorry, are you asking me or the audience?
What's the etiology of this? What is the etiopathogenesis?
So in our evaluation and workup of him, we did not identify any history of trauma, thrombosis, infection. His hypercoagulability panel was negative as well. So we couldn't actually identify an etiology for him.
So these whatever you listed, those are the causes of, and sometimes the, you made a point that the patient, the sinus occlusion, venous sinus occlusion may not be an issue because it's a chronic presentation. But many times the chronic sinus occlusion is a precursor to this, the dural venous fistula. So when the sinus get occluded over a period of time, they may have a chronic presentation, and that's one of the ways also they present. So it's not necessary that a patient has a chronic presentation, the sinuses will be normal, right? The other question I have for you is, do you have any of these dural fistulas who are better managed? This, of course, is a very well managed case. But there are cases where the dural fistulas, AV fistulas, are better managed, more definitively managed by microsurgery. Would you have some cases where would you think that microsurgery may be the better option?
Definitely. I think microsurgical obliteration or disconnection of the fistula is quite definitive with a very high cure rate. And there are many instances where that is the first line. For instance, if the if the fistula is not accessible from an endovascular perspective, or if it has been embolized in the past and has recurred and now is inaccessible because of embolizing material. So I think there are a few examples in which that is.
Which area dural fistula are better managed microsurgically? Would you be able to tell us that? Where is the fistula located, which are better managed by microsurgery? In your practice, in your department, would some of these cases be microsurgically managed?
I think a lot of times when the dural AV fistula is superficial and accessible, we consider that. I'm personally not a neurosurgeon by training, so I may not be.
All right. Okay, that's fine. That's all right. Okay, Sarah, please go ahead if you have any comments, questions. So you are a radiologist. What are you, Hazem? Are you a neuroradiologist? You're not a neurosurgeon, you said.
Neurologist.
Neurologist. Okay, please. Go ahead, Sarah, please. Yeah.
Oh, thank you, Hasim. Brave coming into this crowd. That's now, most of our dural, where I work, I mean, I don't do vascular anymore, but most of them dural AV fistulas do seem to come to surgery just for the durability. Although we do a lot of interventional work, but dural AV fistulas tend to come to surgery if they're surgically amenable.
Well, we work with good endovascular people, and they will certainly be prepared to have a first go at most lesions. But obviously, there are. I think basically anterior fossa fistulas are typically very difficult.
Yeah, the very easy surgery, and they're very well. Can be obliterated and much more definitive. The greatest problem with this, to my mind, the dural AV fistula is the recurrence over a period of time. They recruit more vessels and embolization, and quite often some of my endovascular colleagues, they would block the sinus. They will pack it. The sinus is occluded, so they pack it. I mean, that is the etiology, but they block it, and somehow it's a little bit of paradox. They starts with that, but they block it, everything, and so they does not reform. Any other questions? Anybody has a comment? Then you can, Hassem, you wanted to show us some literature. If there is no other comment, you please go ahead and tell us what you want to tell.
Sure. So everybody in the audience, I'm sure, is quite aware of the literature, but dural AV fistulas are not uncommon. We see them in 50% of intracranial vascular lesions, and they're largely acquired based on the etiologies that we discussed, like trauma, thrombosis, thrombotic states, prior craniotomies, infections, and the presentation varies significantly based on the location of the fistula. Now, in terms of treatment options, just categorically speaking, we either speak of microneurosurgical, endovascular, which could be transarterial or transvenous, or radiosurgery or gamma knife surgery. When we talk about the endovascular approach to treatment, so currently we think of the possibility of achieving curative endovascular treatment of those fistulas, although that in the literature of the embolization agents that we have, we see that cure rate in about 80 to 85% of the cases in the case series that I've seen. It also could be adjunctive to surgical treatment as a preoperative way of reducing the blood flow to the fistula and making the operative outcomes easier and less taxing in terms of blood loss. There's also been a few case series of using a combination of endovascular and surgical techniques in the same setting, where the surgical aspect would be to gain access to a vessel that is otherwise inaccessible, either because of prior embolization or anatomical location, and then endovascular embolization through the surgical access. And then in terms of the endovascular embolization, it could either be transarterial or transvenous. Transvenous seems to be very promising because it has a high chance of obliterating the fistulous communication and the venous outflow completely. We see that, for instance, a lot in carotid cavernous fistulas. Transarterial is is also quite reasonable, with, again, about 80% cure rate if the embolic material penetrates into the fistula. The embolic agents that we routinely use or currently use include onyx and nowadays fill. Onyx is the older of the two agents, which is an ethylene alcohol called polymer that is dissolved in DMSO. It has some caveats. It is mixed with micronized tantalum powder. So sometimes the tantalum powder will precipitate and may block the microcatheter during the injection. So that can sometimes be a little bit more technically challenging. And also because of the possibility of precipitation of tantalum, we have to prepare onyx by shaking it for about half an hour before injecting, which just technically sometimes adds more steps. Fill is a newer agent that is a non-adhesive copolymer that's also dissolved in DMSO, but it is covalently bound with iodine, and so it doesn't require any of that preparation. It's essentially just ready for injection.
Just wait. Can you? I see that Bill is here. He was busy with something. What's your practice, Bill? What's your practice of dural fistulas in your department? I mean, how much microsurgery, how much endovascular? What's your?
Sure. Yeah, I mean, I agree with Teet that we would give first right of refusal to our endovascular colleagues, and Onyx has been a game changer in this business, and we treat most of them with Onyx. And we use surgery as a backup. The anterior ethmoidal ones we usually operate on, but the ones that are the most common ones that we see are these ones around the transverse sigmoid junction, and those are almost always done endovascularly for us now. Yeah.
Yeah, I think we would agree with that. The most posteriors are the first, the first line of management is endovascular. We also have the same kind of protocol. I was, there was this gentleman, I can't remember his name, but he's from Germany, from Frankfurt. And this neurosurgeon who had come for a meeting. And I was told in Germany, unlike aneurysm, which is the first right of refusal is by endovascular, the dural fistula, the first right of refusal is by the neurosurgeon. If he say that he cannot, then only they go for, this is in Frankfurt. So that's why I was interested to find out what's the protocol in other places. But like Bill and Teet said, that except the anterior ethmoidal, most posterior would go for endovascular first. But the anterior ethmoidal, the anterocranial fossa, dural fistulas, I think are easy surgeries and more durable. So we would offer surgery for that. Yeah, I think Hassan, if you could stop, because we are getting late. I think the guys in the ladies in Australia, we are taking them to task. It's becoming very late. We have one more presentation by Zepe. I think we'll go on with that first. If you could stop sharing, please.
Of course, thank you.
Yeah, Dr. JP, I think he's back. He was unwell, but I am sure he's fine now, and then do the presentation. Dr. JP, can you please share your...
Yes, can you hear me?
Yes, very well.
Okay, and see me also, good. I'll just try to share screen here. All right. Can you all see it?
Yeah.
All right. Thank you. Thank you very much. My name is Jeppe Lofert Haslen Winding, and I'm a medical doctor at the Department of Neurosurgery at Copenhagen University Hospital in Copenhagen, Denmark, and I'm a first-year resident. And I would like to thank you and Professor Teet Mathisen for the invitation and the opportunity to present this case, and a special thanks to senior consultant Lars Poulsgaard for providing data and helping me with this case. So the patient history, excuse me, in March 2008, a 30-year-old male with a past medical history, including several years of migraine-like headache, schizophrenia, depression, and periodic alcohol abuse, was referred to the hospital with symptoms of severe headache, dizziness, and with objective findings being left-sided hemiplegia and cerebellar symptoms. The primary brain CT and MRI revealed a large tumor located close to the cerebellum, near the midline of the left side, adjacent to the tentorium. Primary surgery with gross total resection was succeeded in March 2008, followed by stereotactic radiotherapy with 54 gray in total. Since then, the patient suffered from relapses at different intracranial locations 9 times and underwent 9 surgeries with 7 gross total resection and 3 times with the radiotherapy. All radiotherapy intervention resulted in regression of the tumor at follow-up. The patient was operated for the 9th time with this year in September. And then I will just present a few of the relapses MRIs to give you an idea of the different location during the years. So the second relapse was September 2012. And here the tumor is seen in the left posterior fossa near the left jugular foramina. The patient was operated again with the gross total resection and radiotherapy with the 18 gray in total afterwards. Then we jumped to the 7th relapse in May 2019, where the patient had surgery again, this time at 2 different places, and once again with the achievement of gross total resection. And here, one of the sites, the tumor is seen near the medial wing of the sphenoid bone, adjacent to the anterior clinoid process. And this year in September, the patient suffered from his 9th relapse and had surgery again at 2 new sites, and again with the total gross resection. And here the first site was on the lateral side of the cavernous sinus, where you see the arrow. This is a rather small tumor, and on the second side, in close relation to the left acoustic meatus. He is now recovering from last surgery and is suffering from diplopia, headache, and reduced resistance to stress, and is awaiting his next follow-up MRI. The patient is an artist, and he mostly paints and do music, but he's still able to make music and go to concerts in spite of all these operations. So this one is just to show you a more detailed overview with the description of the MRI, not presented. That's the blue star marked. I think we can go back to that slice if you're interested. So, of course, the answer is already given after the first operation back in 2008, but I don't know how you want to proceed, if you want the diagnosis right away, or if you want to discuss the case and make a proposition.
I just wanted to ask you, the first time when it was operated, what was the biopsy? What was the histology? Is it meningioma grade 1?
Yes, I can tell. No, on the presentation of the MRI and the CT.
Well, why wouldn't we say that this is a very typical history in a way? This is a very typical history for what it is.
No,
so
my question is,
would you like to think of a
histology,
of differential diagnosis?
Yes, so the first one, it was thought of a meningioma, but it's not a meningioma. It's another and more rare type of tumor. Yeah, but we can jump to the
hemangioparasitoma.
To the histology.
Yeah.
Pardon? Come again, Bill.
Hemangioparasitoma.
Yes.
Yeah.
That was it. So the primary histopathology showed hemangioparasitoma grade 3, and the histology has remained the same during these 12 years, according to different guidelines, but also the latest WHO 2016 guidelines. So by microscopy, the hemangioperitomas are characterized by more than 5 mitosis per 10 high power field, and a patternless architecture, and then this branching staghorn-like vessel that is seen on the picture, on the right picture.
Okay, has this patient been evaluated by PET CT whole body? Has any time PET CT has been done?
Yes, every time at each follow-up there was not at each MRI, but I think every 6 months whole body to check for metastasis.
And there is no tumor anywhere else, correct?
No.
Okay. Yeah, because I have patients where they have the lung lesions, and I know the last patient, which I still remember. I mean, he's being still active. I mean, I probably have operated now 6 times, not 9 times, and he has had gamma knife, cyber knife, proton beam at different times, and he has lung lesions, which are very, very indolent, and it's over 2 years now. The lesions have not changed, so that was a little surprise to me. Whereas the lesions in the brain keep on increasing, which we keep on operating, and nothing we have done for the lung, because we just kept a period of observation. There was no change, and picked up on PET CT, and it's now just a little less than 2 years now. Since it was picked up, but nothing has happened. I just wanted to know, because this is the first time I have seen something like this. So what anybody has experience, and what would you do for that?
Well, frankly, I don't know. I think I'm only familiar with a handful of cases here, and I don't think in any of those cases.
I'm asking Teet or Bill, you have any experience?
Okay,
of...
sorry.
With metastasis, I don't know. Go ahead, Teet. I don't have any experience with metastasis. I'm sorry.
I have experience. Well, I worked for many years in Stockholm and in one place. So we followed our patients, and I had maybe 10, 15 hemangioperitocytoma cases, and the phenotype's a little bit different, but definitely a handful of cases that were exactly like this. When you operate the primary tumor and patient is doing well and something pops up, usually in a different place, you operate, or also respond very well to gamma knife radiosurgery for control. Clearly, we have a sort of sarcoma protocol. So these patients are frequently or regularly assessed with whole body PET or CT for metastasis. But in my experience, the systemic metastases are quite rare with hemangioperitocytomas. But these patients are operated time after time after time. We tried a couple of patients with interferon therapy, but I'm not sure whether the tumors were worse or interferon was worse for the patients, but they were controlled for a long time. But the main problem that we have seen when we lose control is when the hemangioperitocytomas, when they grow, is the vasculature, they grow close to the large arteries and different from meningiomas that are typically vascularized from the external circulation. The hemangioperitocytomas have a bad relationship and vascularization from the internal relationship. And when they grow on or around the big arteries, they are not dissectable. The endothelium becomes part of the tumor. And that I think that's where we have had the big problems, and not being able to remove a tumor or having to remove tumor along with vessels. So these are then really difficult, but many of them behave like this was a grade 3 tumors, but most are grade 2s, and I think they are well treated as chronic diseases.
So Teet, you have some metastasis cases, and what had happened to them? Do you remember anything?
I don't remember that any of them has been problematic. I think we had one patient who probably died 15 years ago, who we followed for 10 years, may have died from lung metastasis, but that's the only one.
Sarah, anybody else has, we still are not sure because nobody knows what to do because patient is completely asymptomatic for the lung. It's not increasing on the follow PET. So we're really not sure whether we should be treating or not treating. So that it's grade 2 hemangiopericytoma, it's not grade 3, grade 2 hemangiopericytoma in the brain.
When I was working for Kate Drummond, she had a case of a patient who had a hemangiopericytoma resected many years ago, who presented with a liver metastasis that had some, really had the liver surgeons baffled. And she was overseas when the patient presented, and she couldn't quite believe she was hearing, you know, what was being told to her. But they're so very rare. You almost never hear of them. That's the only one that I've had anything to do with.
Okay, let's hear from the literature. You're talking about Epe. I don't know how to pronounce your name. I'm sorry. So please go ahead.
You're doing it right, almost. Okay. Yeah. So about the intracranial it's an intracranial solitary fibrous tumor, and they're very rare. As you already know, it's under 1% of all primary CNS tumors, and they're of mesenchymal origin, and highly challenging to treat. And at a glance, they look just like meningiomas on neuroimaging. At most are dual-based, often supratentorial, and about 10% is spinal. And gross total resection can be achieved, but recurrence is seen in roughly over 75% of over 10 years. Also with a significant risk of developing extracranial metastasis. And the pathological history of hemangiopericytoma is also a bit complex, and the definition has been changed a number of times over the years. Last in 2016 with the new WHO classification. But most hemangiopericytomas contain a genomic inversion with a fusion of the NAP2 and STAT6 genes, leading to a nuclear overexpression of STAT6, which is then which makes the most the best immunostaining diagnostic tool. If you look for the expression of STAT6, yeah, and they are probably arising from the fibroblast in the meninges. All right, and so just to the outcome, in spite of all these surgeries over the years and the radiotherapy, also he's living a relatively normal life, and as I said before, now suffers from diplopia because of fourth nerve palsy and complaints of reduced resistance to stress and concentration problems, and the feeling of reduced creativity. But as I said, all the CT scans of the neck, thorax, and abdomen have all been without signs of metastasis. Yeah, so that's just what I would like to discuss. I don't know if you have anything else, but yeah, like a recap, there's been 9 relapses, but no signs of metastasis. And it wasn't recognized on the initial neuroimaging, but was thought of as a meningioma. Yeah, and it was followed a strict.
The patient has done very well for grade 3 hemangiopericytoma. I mean, he is still intact, and other than the tumors, there is no metastasis, which your literature suggested that extracranial metastasis is not rare. I think I read it correctly, if I read it correctly. And in grade 3, other than, like Teet, you said, other than if they're not close to a vessel, they're not very difficult surgeries. And every time I've gone in fact, unless until, some of these hemangiopericytoma are very vascular, the ones which come out in the surface and involve the dura and the bone. They're very vascular. They take the extracranial external carotid circulation and they bleed a lot. But the guy which I mean, the multiple recurrences, they are all, the first one was paracellular, and then he has had multiple tumors at different places, but nothing has come out of the dura, and they have not been very bad. So I think there are two different types of hemangioperiscytoma, probably. I don't know. From my surgical experience, I'm telling one type which is very vascular, very aggressive, very invasive, and the other one is not so much.
No, I agree, Basant, but I think there is a difference on how they derive their vascularization and whether you're able to control it or not. Typically, meningioma, you can control the vascularization early. Sometimes you can also in the hemangioperiscytomas, but not always. And they can have a little bit different growth pattern. But I agree with you. But of course, all the credit for this case and the fact that the patient does so well goes to Lars Polsgaard, my colleague here. Because Jeppe was sick with COVID, and then I was sick with COVID. So we are actually both struggling with a rehabilitation program and realizing that the recovery from anosmia, one of the important things is to relearn, to recreate the memory and connect your memory of what the smell was like with the smell. So Jeppe, who is a great winemaker, has devised and designed a rehabilitation program or wine cellar where we have to go through all the different grapes and districts to recognize what they smell like.
Yes.
Yeah, that's interesting. Well, so both of you are down with COVID, right?
Yeah.
So, and you say that Denmark is not very badly affected.
So
it's coming for all of us.
Well, you go through that rehab program without COVID?
Badly affected.
Pardon?
The mink industry is badly
rehab
affected.
Program without COVID?
Yeah.
So
one last thing, can I ask you, what are your thoughts about the radiotherapy? Because in this case, the patient have suffered from sequelae after radiotherapy. He has felt he's been more, how to say, he's been more affected after radiotherapy than after the surgeries. And I think that's why the last radiotherapy was back in 2012. And since then, it's only been surgery. Is that a pattern that you see also?
I think one has to differentiate two things. One thing is radiotherapy to prevent recurrences, and another thing is radiosurgery for a residual or for a definite tumor. I think that's really important to differentiate. With radiosurgery, where you have a small target, you can definitely control lesions. But in my book, the hemangioperiscytoma is a typical lesion where you read guidelines where people have no experience and for some reason think that there is evidence that all patients should have radiotherapy to prevent recurrences based on very, very, very low evidence, retrospective studies, etc. So
my case, which I'm talking of multiple surgeries,
yes.
Every time, I mean, he's like your patient, he's completely functional. I mean, he's 70, but every time we have given only radiosurgery. I mean, it's no radiotherapy anytime. But I agree with you, when there is hemangioperiscytoma grade 3, I think the standard of care in the literature is radiotherapy, not radiosurgery. I agree with you. But this gentleman, which I'm talking of, the guy who has a lung lesion, and he's completely functional. He has had gamma knife, he had cyber knife, he went to US to get the proton beam. So he had twice gamma knife, one cyber knife, one proton beam. This is only to tumor bed, not for tumor. I mean, we have removed and we have given tumor bed radiosurgery all these times.
Yeah. So one thing that I'd just like to comment on is, and I think Teet is much more knowledgeable about this than I am, but the one thing that we do is, and we have a number of these patients with multiple meningiomas in different locations that get treated with radiation. And so during our tumor board, what our radiation therapists like to do is they like to add up the dosages. And it goes back to your question, Epe, whether you can have cognitive problems and difficulty with the radiation. It does add up over time, and especially if you use radiosurgery or radiotherapy, stereotactic radiotherapy on these cases. And so we've had a number of cases where it's effectively, we've given to the base of the skull everywhere, and they've given almost like whole brain radiation, you know. So, but maybe Teet has more comments about that than I do.
No, I just agree. I have a half-finished manuscript with, I don't know, between 7 and 9 patients with parasagittal meningiomas who had multiple recurrences, multiple radio surgeries, extensive white matter degeneration and dementia, motor symptoms and things like that. So it's absolutely, the radiation adds up, and one has to be aware of that when treating many lesions at different times, also with radiosurgery. I completely agree, Bill. Thank you for bringing that up.
So would you say that surgery is first option if possible?
I would absolutely say surgery is first option, and I would be very hesitant to recommend fractionated radiotherapy to prevent recurrence. I think Bazant's idea with giving radiosurgery to the tumor bed is something that we need to study prospectively a little bit more. I think that's a very good idea. And that might be efficient, but we have too much of confusion between different radiosurgical and radiotherapy paradigms, and typically radiation is prescribed either if we have nothing to offer, or when we have operated something like a hemangiopericytoma grade 3 that sounds very bad, so we think we should at least give radiation to give them a better chance, without having very good evidence for it.
The other problem is not a common tumor. You know, you don't see so many to give a kind of protocol. I mean, so these are all anecdotal cases. So that's a problem. That's a major problem.
Yeah, that's the thing. We should collect our anecdotes and collect the experience.
That should be your next project for academy, I think.
Yes, why not?
So, you know, I think that's a great idea, Basant. We need to collect the experience. And this is the problem with skull-based surgery, is that you've got senior neurosurgeons with good anecdotal experience, but we need to add it up and make some meaningful recommendations. So I think that's an excellent suggestion. We should do that.
Okay, so if there is anything burning comment, anybody else? Otherwise, we'll wind up. I see Sarah has disappeared now, I think. Other than that, everybody is there, and Isabella probably got stuck in the flight, so we haven't seen her here. But thank you very much. Thank you, everybody. Thank you, Bill, for a very, very elegant presentation. Teet, for your contribution. And all the young neurosurgeons, Sarah, and also the faculty, Sarah, Salman, and unfortunately, the couple of faculty could not join us. But all young neurosurgeons, thank you very much. We really enjoyed it. Thank you.
Oh, thank you.
Thanks, Basant.
Thank you very much for organizing this. This is great.
Great job.
And with these young neurosurgeons, I think Basant, you, Bill, and I can be happy with the future coming up. So.
Yeah, I agree. I agree with you. Thank you very much. Appreciate it. Bye-bye.
Be well. Thank you.
Ronak, please stop live.
हेलो
स्टॉप रिकॉर्डिंग कर दो स्टॉप रिकॉर्डिंग कर दिया डू यू वांट टू स्टॉप क्लाउड रिकॉर्डिंग यस चलो अर्षद गया उसने स्टॉप कर दिया क्या नहीं रौनक को नींद आ गई
ठीक है चलेगा
ये तो बहुत ज्यादा चला आज
8:30 हो गए
ठीक है
ठीक है चलो बाय गुड नाइट
बाय गुड नाइट